So my final diagnosis, my final diagnosis we made was Freddy syndrome. As the patient was presented with RA, and also patient had splenomegaly and neutropenia. Treatment we given was patient to 3 pints of PCV, Dex volumes, and injection ceftriaxone 1 gram intravenous twice a day for 5
Okay,
days.
okay. I just interrupt you. So, your diagnosis, this case is of Felty syndrome, right? So, what
Yes,
is a
sir.
classical triad of Felties? What is Felties triad?
Sir, classical triad of Felty includes rheumatoid arthritis, neutropenia, and splenomegaly.
Usually, what kind of rheumatoid arthritis is seen in Felties?
Sir, it is seen as erosive arthritis. Extra articular manifestations are seen more.
Okay. What else?
Uh,
Seropositive, seronegative.
it is seen as seropositive, sir.
What is
Seropositive.
seropositive means?
Seropositive means presence of R effector positivity, and also patient shows anti-CCP antibodies positive.
Okay. So, what are your differentials for Felty syndrome?
Sir, most common and which can be linked to Fell's syndrome is LGL, large cell granulomatous leukemia.
What else?
Uh, Others, I have not identified.
How you will differentiate Felties versus LGL?
Uh, Pardon, sir.
How you will differentiate on bone marrow aspiration biopsy that this is
Yes, sir.
Felties and this is LGL? What is
Uh,
LGL?
Sir, LGL is a large cell granulocytic leukemia, in which there is
Okay.
presence of fast ligand, and in Fell's syndrome there is a hyperplasia of myeloid cell which shows in autoimmune activity uh, on HLA-DR1 gene.
Okay. And the bone marrow aspiration biopsy findings of Felties?
Uh, Sir, same on bone marrow aspiration findings, there is hyperplasia of myeloid cells, myeloid myeloid link, and uh, hello.
Yes, yes.
Yes, sir.
Okay.
There is
So
absence
how,
of fast ligand. Fast ligand is not present in uh, Fell's syndrome, which is present in uh, LGL, sir.
okay. So this patient comes to you in your OPD with HB of 4.4
Yes,
with a
sir.
WBC of 1000 and platelet of 33,000. What is your first impression?
Sir, my first impression will be pain cytopenia.
Okay.
Yes, sir.
What you will order next?
Sir, basically, we will on basic test we will order CBC with the peripheral blood smear,
Okay. What
which
you
I
are
will be.
expecting in peripheral blood smear?
Uh, Sir, I'm expecting peripheral blood smear of microcytic picture or reduced platelet counts on smear.
Okay.
Yes.
Anything else?
No, sir. Anything else not cannot be expected in pain
Okay.
cytopenia picture.
So how you will manage this case?
Sir, this patient of Fenty syndrome should be managed for the root cause of rheumatoid arthritis to prevent complications. A patient should be started or must be started on DMARDs with low dose DMARDs such as methotrexate 7.5 mg.
Okay, you give methotrexate and it is refractory to methotrexate. What is the
Uh,
next drug of choice?
Sir, we can give leflunomide in such cases.
Anything else?
Uh, Sir, if a patient is having no activity against DMARDs, we can start steroids also in such patients.
What is the role of rituximab in this?
Uh, Sir, rituximab also it is a monoclonal antibody. It is also having a role when patient does not respond to DMARDs in biologics. It
Okay,
causes.
fine.
Uh,
Okay, fine, fine, fine.
Thank you, sir. Thank you so much.
Yes, yes. Okay, we'll close the call. Okay.
Yes, thank you so much, sir. Yes.
profiles, necessitating specialized approaches to diagnosis and management. Recent advances, including the application of squash cytology as an intraoperative diagnostic tool, have revolutionized neuropathological practices. This technique facilitates rapid assessment, guiding neurosurgeons in tumor resection while complementing histopathological and molecular analysis. The aims and objectives of my study are to evaluate the diagnostic accuracy of squash cytology, to assess the concordance between intraoperative squash cytology and definitive histopathological diagnosis, and to analyze the spectrum of CNS tumors in pediatric and adolescent population. This descriptive observational study was conducted in the Department of Pathology, Madhevappa Rampure Medical College, Kalburgi, between the period of July 2019 to October 2024, and it included 33 cases. Preoperative clinical details of the patient like age, sex, etc. were collected as per the proforma. The biopsy samples at the time of surgery were transported in isotonic saline fixed in 95% ethanol and stained with rapid HND and toluidine blue. Remaining tissue was fixed in formalin and processed for routine histopathology and immunohistochemistry whenever needed. Results of the study: a total of 33 cases were included in this study, age ranging from 0 to 18 years, with majority cases being in the age group 11 to 18 years. Male predominance was noted, with male to female ratio being 1.5:1. 82% cases were intracranial, cerebrum being the commonest site, and headache was the most common clinical presentation. The same have been tabulated in the following 4 slides. The next table shows different subtypes of CNS neoplasms we encountered in the study, with astrocytic tumors being the commonest, with total 9 cases, followed by 5 cases of medulloblastomas and 4 cases of meningiomas. The table shows comparison between squash cytology and histopathological diagnosis. We identified 4 cases of high-grade gliomas on cytology, which were confirmed as epithelioid glioblastoma, gliosarcoma, and anaplastic astrocytoma on histopathology, and 2 cases of low-grade glioma confirmed as diffuse fibrillary astrocytomas on histopathology. We also encountered 2 cases of pilocytic astrocytomas and 1 case of pleomorphic xanthoastrocytoma. Following are the pictomicrographs of each. Epithelioid glioblastomas are characterized by sheets of epithelioid cells with fibrillary background on histopathology. The tumor is positive for vimentin S100, INI1, EMA, and GFAP with high proliferation index on MIB1. Gliosarcomas show spindle cells in fibrillary background on squash cytology and typical herringbone pattern arrangement on histopathology. On IHC, the tumor is positive for GFAP and vimentin. Diffuse fibrillary astromas showed glial cells in fibrillary background on both squash cytology and histopathology. Pilocytic astrocytomas showed atypical glial cells, Rosenthal fibers, and eosinophilic granular bodies confirmed on both cytology and histopathology. Pleomorphic xanthoastrocytomas showed clusters of pleomorphic astrocytic cells on squash and eosinophilic granular bodies on histopathology. Moving on to the single discordant case in my study was a case we diagnosed as meningioma on squash cytology, but later confirmed as ganglioglioma on histopathology. Here are the images showing round plump cells arranged singly, and intracytoplasmic inclusions can also be seen. So we diagnosed this case as meningioma on squash cytology, but on routine histopathology examination, we observed plenty of ganglion cells showing pleomorphism, and also lymphocytic infiltration was noted. The case was confirmed as ganglioglioma on IHC, showing GFAP positivity. We also encountered 1 case of dysembryoblastic neuroepithelial tumor characterized by loosely arranged round cells, and the tumor is positive for CD34 S100 and showed 5% Ki67 index. We also studied 2 cases of ependymomas showing loose clusters of round to oval cells with radiating processes on cytology and perivascular pseudorosettes on histopathology. Also noted 5 cases of medulloblastomas with clusters of tumor cells and showing hyperchromatic nuclei on cytology and syncytial arrangement of undifferentiated cells on histopathology. We also noted cases of neuroblastoma, atypical teratoid rhabdoid tumor, schwannoma, and 4 cases of meningioma. Atypical teratoid rhabdoid tumor characterized by small round blue cells on squash cytology and atypical glial tissue. The cells showed rhabdoid chondroid differentiation on histopathology. Special stains like periodic acid shift stain and mucicarmine were performed. The tumor is positive for vimentin, S100, GFAP, cytokeratin, etc. Following are the pictomicrographs showing classic features of schwannoma, meningioma, primitive neuroectodermal tumor, Langerhans cell histiocytosis, mature teratoma, germinoma of pineal gland, and craniopharyngioma. This is a table showing comparison between radiological and histopathological diagnosis. We noticed a statistically highly significant correlation between the two. Following table shows histological subtype-wise distribution of CNS neoplasms. As I mentioned, we observed maximum cases of astrocytomas, total being 27% of the study, followed by 5 cases of various medulloblastomas. This table shows WHO grade-wise distribution of neoplastic lesions. Most cases, that is 13, were in grade 1, followed by 10 cases in WHO grade 4. This is a table mentioning the discordant case in our study. The table shows high sensitivity and specificity. Coming to the discussion of the study, the current study reflects global trends showing male predominance, higher incidence of intracranial tumor and astrocytomas as the most prevalent subtype. Squash cytology proved highly accurate with minimal discordance. Significant correlation with histopathology and radiology highlights the importance of a multidisciplinary approach. Predominance of low-grade tumors emphasizes the critical role of early detection. Coming to the conclusion of my study focusing exclusively on the CNS neoplastic lesions reinforces the role of squash cytology as a reliable, rapid, and cost-effective operative diagnostic tool. Findings of the study aligning with the global trends affirm the utility of squash cytology in guiding neurosurgical decisions, especially in research-limited settings. In summary, my research not only emphasizes the significance of squash cytology, it also advocates for a multidisciplinary approach to optimize the surgical outcomes and improve long-term prognosis for pediatric and adolescent CNS tumors. These are my references. Thank you.
Very nice presentation.
Thank
It was
you, ma'am.
interesting to note that you had, I think, over a period of 5 years, right?
Yes, sir. Yes,
You
ma'am.
had 33 cases,
Yes,
as
sir.
I saw.
Yes, ma'am.
And you have quite a gamut, a very broad spectrum of lesions.
Yes, ma'am.
So some of the very rare types also you did include.
Yes, ma'am.
What I want to know from you is what is your reference telling you about your incidence or the prevalence of tumors and the others
Yes, ma'am.
in our country only? I don't want to know any
Yes, ma'am.
international.
Yes, yes. We referred the studies, Udaygiri et al. And Ashirvadam et al. These are all studies are done in India only, ma'am, taken from different states, so that we specifically focusing on the North Karnataka region, we did the study. So similarly, from Indian articles only, we have taken all the references.
Yeah, but you had a comparison where they also had more of astrocytic
Yes, ma'am.
tumors
Yes, ma'am.
and similarly
ma'am.
meningiomas. Now,
Yes,
could you
ma'am.
explain why there was a discordance? Why you did not get any ganglion cells in that case where you called it a meningioma and on
Yes,
it?
ma'am. Yes, ma'am. As we know, gangliogliomas are biphasic tumors, but in case of our squash on the same case, we got a very hypocellular smear, ma'am. So it may have affected the biphasic pattern, which we would not be able to identify on squash cytology.
Okay, my last question before I hand over to Madam
Yes.
is, what is the time frame in which you are reporting the squash cytology and how is it really improving on, like we do a frozen intra-op.
Yes.
So how is this contributing to the surgeon?
Okay, ma'am. Squash cytology we report within 20 minutes, ma'am. The neurosurgical OT and neuropathology, very 5 minutes the specimen will reach to us. Within 20 minutes, we have to give the diagnosis to our surgeon. And on frozen, it takes 1 hour to 1.5 hour based on staining, ma'am. And, not on our basis, only based on staining and how fast it reaches to us.
So your neurosurgeon is waiting for your report and then he's deciding the extent of surgery on that, based on that?
Based on how much of the tumor to resect, yes, ma'am.
Yeah. Now, when what I'll tell you from my experience,
Yes,
when we did the squash cytology in
Yeah.
our hospital, and the neurosurgeon told me that irrespective of what is the grade, he would have, like, even in a very in a glioblastoma kind of
Yes,
thing,
ma'am.
he would do whatever possible resection because it is an infiltrating tumor.
Yes, ma'am.
So he would not be able to remove everything because he may damage some normal brain
Yes,
tissue
ma'am.
in the process.
Yes, ma'am.
And he said whatever extra would be left behind would be taken care of by the ancillary
Yes, ma'am.
post-op modalities
Yes, ma'am.
as well.
Yes, ma'am.
So I just
So,
wanted to tell you this, that
yes, ma'am.
I mean, if they are waiting for your report, that's really good. But nowadays they do it by the suction, so you
Yes,
get
ma'am.
small bits and pieces. And one other reason why you could have missed out is, like, we have also observed this,
Yes, ma'am.
that sometimes the tissue that is sent to us is really less or is not
Yes, ma'am.
representative.
Yes.
So there you can get a discordance.
Yes.
Very
I'll
nice
note it.
presentation.
Thank you, ma'am.
So can squash cytology replace frozen sections?
At a near future, yes, ma'am. Very much so.
So where else you can use this squash cytology?
We can, the whole point of doing squash cytology is to diagnose it as either benign or malignant, so we can uh, process it further with the treatment, ma'am. So we can do it for other tumors as well. For thyroid we do, for imprint cytology we do, for frozens also, ma'am.
Okay, thank you.
Thank you, ma'am.
Thank you so much, Dr. Shweta.
Thank you.
What a good title it was. Little Minds, Big Challenges. Now I present next presenter. Now I would like the next presenter, Dr. Kavita Bobde, resident from MIMSR Medical College, Latur. Please keep the timing in mind, that is 7 plus 3, 7 minutes for the presentation and 3 minutes for the discussion.
Yeah. कहाँ पे है? येलो
Please start. Your time starts now.
Yes. Good morning, everyone. Myself, Kavita Bopde. I'm from MIMSR Medical College, Latur. I'm going to present a paper on histopathological study of prostate lesions. First, introduction. The diseases of prostate gland are important source of morbidity and mortality in male patients. The increasing number of cases over past decades are due to the higher life expectancy. The spectrum of diseases consists of inflammatory conditions, hyperplasia, and malignancy. The prostate biopsy is essential to detect cancer and other benign conditions. There are other modalities of diagnosis comprising of radiology, prostatic biomarkers. However, biopsy with histopathological examination is gold standard for final diagnosis. Aims and objectives for my study are to evaluate various histopathological lesions of prostate. Second is to study incidence, age distribution, and histopathological features of lesions of prostate. Materials and methods of study. Total 106 cases of prostatic lesions from November 2023 to November 2024, including TURP chips, were evaluated in this study. The received specimens were fixed in 10% formalin and routine paraffin processing was done, followed by H&E staining. All specimens were analyzed with following parameters, that is a type of a specimen, age, medical history, histopathological examination, and final diagnosis. Results and observations of my study. First, age-wise distribution of cases. The most common benign cases were in the age group of 61 to 70 years, and malignant cases were in the age group of 71 to 80 years. The distribution of histopathological lesions. The most common lesions were of benign prostatic hyperplasia, and the second most common were the adenocarcinoma. The cases distribution according to Gleason score, where the most common cases having the Gleason score of 7, which are 4. The distribution of cases according to Gleason's grade. The most cases were in the Gleason's grade 4 and 5, which are 30 to 30%. The images. First is benign prostatic hyperplasia, which shows the glandular and stromal proliferation. In second image, it shows the lymphocytic aggregates, and in third image, it shows the microabscesses which are of acute prostatitis. In next image is of high-grade pin. It shows the more basophilic glands than the normal, and it shows the nuclear overcrowding and atypia in the luminal secretory cells. Next image is of adenocarcinoma prostate grade 2, which is having score 7. The predominantly well-formed glands are there, and lesser component of cribriform glands. Next image is of adenocarcinoma prostate grade 4. There is a predominantly a lack of gland formation. Next image is of adenocarcinoma prostate grade 5. There is also a lack of gland formation. Discussion. We have compared the present study with others, and we found that the majority of age group affected is 61 to 70 years. And the most common lesion was benign prostatic hyperplasia. And the most cases of Gleason score were found in grades Gleason score 7 in present study. And in other study, it were in also grade 7. And in Bhattaiyal studies, it was in grade 9, score 9. So conclusions, in the study of 106 cases, most common age group affected was 61 to 70 years, and the youngest patient was 49 years old, and old was 85 years. In study, various histopathological patterns were observed, where BPH was most common finding. We reported 10 cases of adenocarcinoma of prostate with application of modified Gleason's grading system. So it is necessary to study all prostate biopsies in order to identify premalignant lesions, proliferative activity, and grade of inflammation. So histopathological diagnosis and grading play a definitive role in management of prostatic cancer. So these are my references. Thank you.
What are the advantages and disadvantages of FNSC in diagnosing prostatic lesions? This is histopathological study, I
Yes,
know.
ma'am. So we generally not do FNAC of prostatic
Why?
lesions.
We can do. Why we can't do?
Uh, in your conclusion, you have mentioned about prostate biopsy. In your starting also, you mentioned about prostate biopsy.
Yes.
But whatever images you showed us look more like TURP images. So where are the prostate biopsy images? And how many prostatic biopsies did you have?
Oh,
Because your
Mm.
prostate biopsy is going to guide the surgeon further, isn't it?
Yes.
That is what you're trying to say. But then we didn't see any images of prostate biopsy.
oh, ma'am, I haven't take images of prostate biopsy.
No, if the
Uh,
point is that a prostate biopsy is important to decide the further course of treatment,
Mm.
do you know what are the treatment for adenocarcinoma of prostate or
oh,
prostatic cancer? Do you know what is the treatment?
Ma'am, prostatectomy and
No, it's not always prostatectomy. In fact, what is
right,
done is what is the basis of prostatic cancer? Why does it arise?
ma'am, increased level of androgens or dihydrotestosterone.
So the treatment is
Yes.
orchiectomy because you
Yes.
want to have an ablation or you want to reduce the hormones
Hormone.
or anti-hormone drugs are given.
Yes.
So especially in elderly patients where a surgery is not really may not be possible because of other conditions, age, debilitation, etc. So otherwise also now the preferred treatment would be orchiectomy unless the prostate cancer is small and you can resect it. What is because prostate cancer goes on for a very long period. It's a very slow growing cancer and it can persist for a long time and may not be symptomatic till very late, by which time it has infiltrated everywhere. So the treatment becomes either drugs or injectables which are anti testosterone or anti androgen, acting against the receptors as well. And that's why the prostate biopsy is important.
Yes.
So you should have included those images, right? Yeah, so remember for next time.
Yes.
Thank you, Dr. Kavita. That's all for the oral paper presentation. We just had two presenters. Now I would like to request Dr. Rujita Aichit ma'am. I request Dr. Rujita Aichit ma'am to please felicitate Dr. Meenal Patil ma'am. Camera. Camera. Photographer कहाँ? Photographer. Claps करो claps. Please switch on the lights. The PVR team. PVR team को बोल कर live. I request Dr. Rujita Aichit ma'am to please felicitate Dr. Pragati Fulgirkar ma'am. Okay. Dr. Jayashree ma'am, please felicitate Dr. Pragati ma'am. Thank you so much, ma'am.
अभी नहीं, मैंने 10:40 पर पढ़ा।
Hello, hello, chick, hello.
हॅलो हॅलो सर सर एकच आहे का सर लागेल ना मॅडम काहीच प्रॉब्लेम काढते ना नाही मॅडम या ना सर एकच आहे का पीपीटी का भरपूर येत हा मग काही प्रॉब्लेम अदरवाइज अच्छा नाही नाही म्हणजे हो.
नाईट लाईट चालू आहे ते बंद करायचं
काय करायचं
नाईट लाईट
हा
ते येलोच दिसते जरा स्क्रीन
हा
त्यामुळे
काय करायचं
नाईट लाईट चालू आहे ते बंद करायचं ऑफ करायचं
कुठून करणार कुठूनच करायचं ते सगळं
हा काय झालं ते येलोच दिसत होतं आता
हरकत नाही
स्क्रीन
हॅलो
सर यातलं कुठलं आहे एकच हे शेवटचं डॉक्टर ओके ओके स्कॅन हे करतोय कॉपी कर फोल्डर आहे 18 तारखेचं हो आलं ना
बुके अँड मेमेंटो
थँक्यू
वो जो राइट ऑफिसर है ना तो अनाउंसमेंट होने के बाद इधर चेयर कर इधर बैठना है ये पर हाँ यहाँ पे बैठना है
आता ही जी स्क्रीन आहे त्यांनी काय केलं व्हाईट लाईटचं हे करून टाकलं त्यांनी काहीतरी येलो यायला म्हणून ते येऊन गेलं ते नंतर दिसत
नाही
आता इतकं बघा आला
हे कोणाचं
तुमचंच आहे ना
नाही
आपटे सरांचं हे जे आहे ना कॅन्सल नाही सांगतो ना तुम्हाला हे जे आहे ना हे फोल्डर केलंय 18/1/25 त्याच्यात ऐका ना ते सगळ्या त्याच्यात सगळ्यांची डाउनलोड कर
ठीक डॉक्टर विजय
येत आहेत सर ठीक आहे येत आहेत सर
चल आता काही इश्यू
काहीच नाही हे दिसतंय की
हो हे काय मल्टिपल विंडोज ओपन केले ना होत
त्याच्यामुळे होतंय की चव लॅपटॉप मला माहित नाही सर म्हणून मला सर असं
चालू करू चालू करू चेअरपर्सन
Good morning, ladies and gentlemen, esteemed guests and dear delegates. I, Dr. Rajarsh Hanmante, welcome you all in the City of Educational Hub, Latur, on the second day of conference.
Oncopathology workshop was indeed a golden opportunity for each one of us to enrich and enlighten ourselves.
The event was splendid in terms of intellectual exploration as we journey through insightful presentations and stimulating discussion. Let us remember our theme, that is learning together under microscope is really satisfied.
Where the best minds in hematology comes together to explore the advancement, shape the knowledge, shape the future of the vital field. Now, without any further ado, let's dive into our today's promising study.
So, for the today's first session, it is elaborated by the renowned speaker, Dr. Vijay Shirure sir and Dr. Nilkant Poddar sir.
Fellow hemato-oncology in MUHS Mumbai, consultant clinical hematology hemato-oncology and bone marrow transplant.
याच्याहून डायरेक्ट चालू होईल का बघू का
Dr. Nilkant Poddar, sir, he is a senior consultant pathologist from Solapur. He is honorary head of the Department of Pathology at Shri Markandeya Sahakari Rugnalay Solapur. He has more than 25 years of experience in his field. So, for the first session, I would like to invite Dr. Raibhoge sir, Chandrakant Raibhoge sir. He is a senior associate professor from the Department of Medicine, VDGMC Latur, and Dr. Umesh Kanade sir. He is a professor and head Department of Pathology, VDGMC Latur, to kindly chair this session. Dr. Raibhoge sir and Dr. Kanade sir. I request Dr. Vijay Shurude sir and Dr. Nilkant Poddar sir to kindly proceed for the today's presentation.
So good morning, everybody. So it's a privilege to give a opening talk as a opening batsman, that too in front of all the Sachin Tendulkars, Kapil and Gavaskars of hematology and pathology. So I'm privileged to have an opening session for today's CME. So today I'll start with the place where I work. This is the Apollo Hospital, Ahmedabad. I'm going to cover this topic under these headings. First, we will look into somewhat history of peripheral blood smear. Then PBS by AI, utility of PBS, how to prepare an ideal peripheral blood smear, then how to report it, systemic examination, the case-based discussion, and take-home message. So being from a millennial generation, I think few slides are not visible. So can anybody identify who is this German physician, scientist, a Nobel laureate, famous for work in hematology and immunohematology? So is none other than Paul Ehrlich. So why we are discussing Mr. Paul Ehrlich today? Because in 1878, he developed blood staining. He identified 3 types of granulocytes: mast cells, polychromatophilia, and megaloblasts. So as I was saying, being from the millennial generation, we have seen change of our source of knowledge from big fat book to a slim, short tablet with the virtue of the technology. So first of all, I just asked this question to internet, Google and AI. What is peripheral blood smear? So I got beautiful essays written on the peripheral blood smear. So then I searched for PubMed. Then I got to know that the publications on peripheral blood smear are on rise. And many of them are on automation and automated analyzers for peripheral blood smear. So are we at a verge of getting replaced by machines to have a look at our peripheral blood smear? So these 2 articles, one from American Journal of Clinical Pathology and one guideline, International Council for Standardization in Hematology, what they have to say. So AGCP article says that though we have the good eyes to look into peripheral blood smear, but they can't replace the machines, so we have to validate them. And the ICSH says that though we have very good machines, there are some flaws which can be overcome by a human only. So these 2 things are not interchangeable. These are complementary to each other. So the big fat book and the technological tablet has to go hand in hand. So now coming to the utility of the peripheral blood smear. To know the utility of anything, we must know where we stand. So peripheral blood smear is one of the tool. Apart from history, clinical examination, other investigations, and one of that investigation is peripheral blood smear, which helps us for accurate diagnosis and correct treatment of the patients. So how peripheral blood smear helps us? It helps us for diagnosis. It can give a final diagnosis. A peripheral blood smear showing a malarial parasites. We got the diagnosis. Differentials, a microcytic hypochromic anemia, we get the differentials like iron deficiency anemia or thalassemia traits. It can help us in prognosis. Many of the disorders, they have platelet counts or the drop in the platelets or many things which we can see on the peripheral blood smear. Monitoring of the response to the therapy along with the toxicities of the therapies. And once again, as I said, validation of the automated analyzers. So peripheral blood smear helps us in each and every step of diagnosing and treating a patient. So how to prepare a peripheral blood smear? So starting from simple things like what kind of slide we should use. The slide should be clean glass slide with the dimensions of 75 by 25 millimeters with thickness of 1 millimeter. Everything is available in the books. Like we can refer any book like Dacey and Levy's for all these things. The spreader should be little bit smaller in width as compared to the slide, 18 millimeter width. Edges should be smooth. It should be placed at a angle of 30 degrees. Smear spread should be smooth. The drop of blood, a small drop of blood should be taken at the center of the slide, 1 centimeter from the one end, and the whole smear should end before the slide ends. The particularly that smear should be of 3 centimeter and that should end 1 centimeter before the slide ends. This is what the ideal way of preparing a peripheral blood smear as shown in this picture A, B, C, D. I have already explained. Then it should be properly labeled. Labeling is very important. So what happens if we don't follow all these procedures? So the A smear is a good quality smear. The second one, B, is an irregular patchy smear because of dusty slides. Thick smear or because of inappropriate angle. The D1 is the irregular smear with long tails because of the inconsistent pressure and irregular edges of the spreader. The last one is the worst because of the greasy slides. So how we should report and read the peripheral blood smear? So this is for lab person, how to report, and one for the ward person who reads the report. The demographics, very important. Identification, very important. So we had one story going on while I was doing my DM that one sister came into the resident's room. 3 residents were having lunch. Sister just said, Kiran ke peripheral blood mein 30% blast hai. And all of them rushed. One had gone to the OPD to get the Kiran admitted. One had gone to the bone marrow room to get a date, early date for bone marrow for Kiran, who was a pediatric child, and one had gone into the ward. Kiran was a 23-year-old lady to break the bad news that she is having acute leukemia. And all 3, when came back, they realized that none of them was right. Kiran was a 78-year-old male who was seen in the medicine ward and he was having the leukemia. So all the story changed. Hence, identification, name, age, sex, always important. So always ask for and write for all these identifications and demographic details. Then clinical summary. Knowing clinical summary is a lab person's right and it's ward person's duty to convey the clinical history. So how we go about the systemic examination of peripheral blood smear? After these demographics, detailed characterization of RBCs, WBCs, platelets, hemoparasites, and miscellaneous things if we have anything. Then summary of the significant findings, impression, whether we can give a single diagnosis or differentials, that should be written. recommended laboratory investigations to confirm what we think, signature and date. These are the mandatory things for a peripheral blood smear examination. So today we are mainly going to discuss about the systemic examination and detailed characterization of all these cell lines. So when I say systemic examination, it has to be in a proper way. SOP should be there. So it starts with the macroscopic examination, how a peripheral blood smear looks with the naked eye. That starts with the macroscopy, looking at the staining, looking at the color, looking at the spread of the smear. Then when we go to the microscopy, it has to be in a systematic way from low power to high power. In subsequent slides, we will see what we should look in this low power and higher powers. And there should be a comprehensive and detailed characterization. Let me stress upon the word comprehensive. We can't just report a RBC picture. We should correlate it with the WBC picture. What are the platelets? What is the platelet morphology? And if anything miscellaneous we are getting on the peripheral blood smear. So macroscopic examination. Just for an example, we can see the first smear, which is very dark and thick. That is a patient of polycythemia. Second one is a normal peripheral blood smear. Third one is very faint. Probably patient is having anemia. The third one is bluish tinge, paraproteins, the gammopathies. The lower left corner is showing how systematic examination for peripheral blood smear is done. It is called as battlement method. In the low power, we should look for any major things or the large things like large clumps of the platelets, which we can see. Then where to examine in high power or oil power, we have to decide in the low power only with looking at the thickness of the smear. So first picture is showing very thin area of the peripheral blood smear that is towards the tail end. The third one is showing very thick area. The ideal area is the area where RBCs are just overlapping to each other so that we can see the morphology of the each and every cell. Then if there is extensive autoagglutination or as I already said, large platelet clumps, we can see on the low power microscope. So this slide I will discuss in subsequent slides. It's showing some cystocytes. Then coming to the RBC characterization, size, hemoglobinization, shape, inclusions, hemoparasites. That is what we should look for in a peripheral blood smear while examining for RBCs. So size. So for getting appropriateness of the size, we must look for an area which is well spread and having a small lymphocyte, because all the size comparisons are done with the nucleus of a small lymphocyte. So this first slide, which is showing a small lymphocytes, and almost all RBCs are of the same size of that nucleus. So this is a normocytic, normochromic picture. The second one, we can see most of the RBCs are smaller than the nucleus of a lymphocyte. So it's a microcytic picture. And third, we can see few of the large RBCs. These are the macrocytes, and few of the macrovalocytes are also present in a case of a megaloblastic anemia. Then for hemoglobinization, usually the central 1/3 part of the RBC is not hemoglobinized. That's what we see as a pallor on the peripheral blood smear. If there is increased pallor, the hemoglobinization is low. We call it as a hypochromic cells. So in this picture, we can see most of the RBCs are having only a rim of peripheral hemoglobinization. This is a case of a iron deficiency anemia, which is showing hypochromia. So then when we look at the size, we not only just see what is the size of the majority of the RBCs, but we also look for the whether there is a variation in the size of the RBCs, which is called as an isocytosis. Then coming to the shapes. Similarly, there can be different shapes of the RBCs in the peripheral blood smear, which is called as poikilocytosis. So there are different poikilocytes according to their size, shape and size. They are named. So the picture in the black bracket is showing spherocytes, the spherical cells. These are the spherocytes. This was a case of a hereditary spherocytosis. The second one, purple one, here also we are seeing some spherocytes, but it is associated with anisocytosis also. So all the spherocytes are not similar. When we have usually a hereditary cause like hereditary spherocytosis, all the spherocytes will be of same size. And in case of acquired causes like AIHA, we will get spherocytes of different size. So anisocytosis with spherocytosis. Then the third one, the green bracket is showing RBCs of two different sizes, microcytic as well as macrocytic. So it is called as a dimorphic anemia, sorry. Then this picture in a third one in first row is showing some broken RBCs or the cystocytes in a case of microangiopathic hemolytic anemia. Acanthocytosis in the liver failure. Then we have teardrop cells, mainly when marrow is packed with other cells or it is fibrosed. Then we get this teardrop kind of cells. Then coming to the sickle cells, we can see beautifully stained sickle cells. The second one I would like to show you, with the presence of these sickle cells, there are also target cells. So this is how we know that this cannot be just a sickle cell picture, but these target cells direct us towards consideration of a beta thal trait or the compound heterozygous state for sickle beta. And the third one is showing beta thalassemia trait with target cells. So these are the list of the causes of different poikilocytes which we see. I'm not going to read through the whole list. We can get it in any standard textbook. So then coming to the hemoparasites and the inclusion bodies. So mainly microfilaria, which can be seen on the high power. That's why that is the importance of high power field examination of the smear. Then these two falciparum malarial rings in insert, we can see the ring forms and a Plasmodium vivax trophozoites. When we see the inclusions, there are certain criteria we should first look at, whether it's a single or multiple, whether it is involving diffusely into the RBCs or it's restricted to some areas. According to that, we can have Hall Jolly bodies, which are the DNA remnants, usually single to the periphery of the RBC seen in megaloblastic anemias, post-splenectomy, and functional hyposplenia. Then Pappenheimer bodies are multiple, seen multiple dots, which are the remnants of ferritin. So as it's a ferritin, that gives positive reaction with the pearl stain. So this is a differentiating characterization between Pappenheimer bodies and a basophilic stippling, which also has a small dots, multiple, but Pappenheimer body as compared to basophilic stippling will not be that diffuse. Basophilic stippling will be having involve the RBCs in diffuse manner. So these basophilic stipplings can be seen in lead poisoning, megaloblastic anemia, sideroblastic anemia, and thalassemias. Then coming to the Cabot ring, these represent the mitotic spindles seen in megaloblastic anemias, certain leukemias, MDS, and myelofibrosis. Then these two pictures are of a supravital stain. One is showing hemoglobin H inclusions that represent the beta globin chains which are precipitated, seen in alpha thalassemias, and the Heinz bodies. These are denatured hemoglobin which is seen in single or multiple rounded basophilic spots in the supravital stains. Now coming to the WBC detailed characterization. So in WBCs, what we should look for? The number, whether these are increased, decreased. Then accurate differential should have at least 200 cell count. That is what the guideline says for the leukemia workup. And for the routine hematology purposes, 100 cell count can be done. So battlement method we have already seen. Then the qualitative abnormalities like nucleus, cytoplasm, and granulations. And importantly, the immature forms. So these are the normally seen WBCs in peripheral blood smear: neutrophils, a small lymphocyte, a large granular lymphocyte, eosinophil, monocyte, and a basophil. Sometimes in females, we can see a indentation out of the nucleus in the form of, which is similar to the bar body in our buccal smear, which represent the inactive X chromosome. So now coming to the abnormalities in the WBCs. Firstly, granules. So granules can be increased, toxic granules, or patients who have received the growth factors. So when we see toxic granules, we must report it. It has a significance. When we see these toxic granules, we must ask for history, whether the patient has received GCSF or not. Both things are important. Reporting to the ward and asking questions to the ward. Then the less granules or the hypogranulation seen in myelodysplastic syndrome, Alder-Riley anomaly, in which there are multiple granules which really overlap all the nucleus and features. Then we have Chidiac-Higashi granules seen in Chidiac-Higashi syndrome. Pelger-Hewitt anomaly, it can be a congenital or acquired. Acquired ones are called as pseudo-Pelger-Hewitt anomaly, which is seen in MDS, leukemias, or CML. Hypersegmentation, or the more than 5 or 6 lobes in the neutrophils. It is suggestive of megaloblastic anemia. Then left shift. In this picture, we can see the band forms, the metamyelocytes, which again indicates for sepsis or the infection. The lymphocytes, small lymphocytes, large granular lymphocytes. Majority of the lymphocytes in the peripheral blood in physiology are small lymphocytes. Few large granular can be seen, but in case of infections, we have transforming or reactive lymphocytes, the third picture. The extreme form of such transforming lymphocytes is seen in infectious mononucleocytes, monocytosis, which is termed as atypical mononuclear cells. Let me remind you, or let me tell you that if we see anything abnormal, we must report it, whether it's in the form of written report. If we are not very sure, we must talk to the ward. What is happening with this patient? I am getting this abnormality. Are these expected? These questions we must ask to the ward. So in immature forms like blasts or other abnormal immature cells, the first picture, which is showing a large cell with high NC ratio, cytoplasm, huge, large amount of cytoplasm, and characteristics OR rod. In the blast, we see OR rod, we can label it as an acute myeloid leukemia. So second one is showing abnormal promyelocytes, which one of the cell showing in innumerous number of the or rods, which is called as faggot cell, very characteristic of acute promyelocytic leukemia. Then the third one is a lymphoblast, ALL. In the middle row, I have kept one that is lymphocytes with the clumped chromatin and a, can anybody tell what is this? Please, louder. Smudge cell, yes. Somebody from here said smudge cell. So this is a case of CLL. Yes, that was a smudge cell. So from CLL going to PLL, a little bit of large cell size with bluish cytoplasm, nucleus, and a characteristic one nucleoli. So this is a PLL. So the next smear is showing this lymphocyte, which is having one characteristic finding. Can anybody point out what is this? Or anything else? Something which is cleaved nuclei, follicular lymphoma, spillover in the peripheral blood smear. This one I think most of you will identify. Hair-like projections, hairy cell leukemia. Yes, peripheral blood smear showing hairy cells. So this was a case of a hairy cell leukemia. The third one is a ALL case, which is showing cytoplasmic bubble-like things. Previously, it was a ALL type 3. It was a case of Burkitt lymphoma. So platelets. In platelets, most important is the number, because everything changes with the platelet number. If it is less than 10,000, 20,000, we have to transfuse. If it is in the elderly, we have to think of leukemias. If in the children or anything, we should suspect for other things. So number is very important. How to number the platelets is an important thing. Most of the labs considers 10,000 to 20,000 for each platelet seen in oil immersion field. That is a that can give rise to a inter observer variation. So the RBC method, we have to count the average number of RBCs in a field and the average number of platelets in those fields, and then with the number of RBC counts which we get on the counters, we have to calculate the platelet numbers, which is more accurate and which will give less variation in the platelet counts. The platelet clumps, these are the enemy of the any patient, because unnecessarily the low platelet count is reported. Patient gets evaluated for thrombocytopenia, gets transfusion and all. Then the clumping or the neutrophil satellitism, which we can see in this picture. These are the large platelet clumps which we can see. Then the morphology, the absence of the granules, gray platelet syndrome. We can see these platelets and we can compare these platelets, no granules. Macrothrombocytosis, the large platelets, which gives us falsely low platelet counts. So till now we have seen that to look at the peripheral blood smear, we have to see RBCs with respect to their size, hemoglobinization, shape, inclusion, hemoparasites, WBCs, quantity, quality, and immature forms, platelet, quality, size, morphology, and we have to look for the hemoparasites. So now we have learned how to report or how to do the peripheral blood smear examination. Let us see few cases, how peripheral blood smear helps us. So case one is a 23-year-old female with symptomatic anemia. Investigation CBC showed 5.5 hemoglobin, low MCV. With low MCV, iron profile was done, which showed ferritin of 8, diagnosed as a IDA, given IV iron. Patient came after 2 months with the report. My hemoglobin still 9.2, it has not gone up. So this time again iron profile was repeated, which was normal. B12 folic acid levels were normal. Thyroid profile was normal. Still patient was having microcytosis. A peripheral blood smear showed microcytic RBCs, anisocytosis, and again the target cells. we can see a small lymphocyte, compare the RBC size and see the target cells. So he underwent a HB electrophoresis. She was a beta thalassemia trait. So they were counseled about this condition and expected HB levels and advice for family screening. So PBF findings are crucial in evaluating anemia. The next case is a 37-year-old male with fever, headache, hematuria, recent history of malaria. CBC showed 7.3 hemoglobin with WBC of 14,000. Neutrophilic predominance was there. Platelets were reported as 2,66,000 on machine count. There were lab findings suggestive of hemolysis, high retic count, LDH, and bilirubin. He was treated as a severe form of malaria with black water fever. But when they analyzed again the histograms, they have seen a peak in the platelet histograms, which is showing there were some large platelets. Similarly, they have found one typical feature in the RBCs, they were having small size. So a peripheral blood smear was advised. And to the surprise, there was no malarial parasite. Platelets are critically low, and we can see these numerous RBC fragments. So he was having severe thrombocytopenia with cystocytes. So ultimately, he was diagnosed to have a TTP. He was started on plasma exchange. However, he had a cardiac arrest and patient could not be salvaged from that. The samples which were collected for the TTP workup showed undetected Adams 13 level and antibody against that. So RBC fragments which have masked the severe thrombocytopenia in a TTP patient. So peripheral blood smear, yes, was a critical in making a timely diagnosis of a life-threatening disease. So next case is a 54-year-old male presented with weakness, bone pain. Investigation showed anemia, thrombocytopenia, and low WBC count with 27% atypical plasma cells. Diagnosis was made with a plasma cell leukemia. He was transfused 2 units of PRBCs with rise in hemoglobin to 7.5. Immediately started on chemotherapy, supportive care, which included a Septran prophylaxis for PCP. 3 days after starting all this, hemoglobin again dropped to 4.7. Everybody was thinking of plasma cell leukemia. He is having plasma cell leukemia. But there were other features of hemolysis, reticulocytosis with low haptoglobin. A peripheral blood smear was advised, which showed, yes, anybody? The ghost cells or the blister cells suggestive of G6PD deficiency. So a diagnosis was a Septran-induced hemolysis in G6PD deficiency. Just last case, sir. Confirmed by low levels of G6PD deficiency. Initially, those levels were mildly low because of effect of acute hemolysis and blood transfusion. Repeat testing after 4 months revealed the moderate G6PD deficiency. He was treated with discontinuation of Septran, blood transfusion, and supportive care. Despite the glitter of leukemia cells, a thorough peripheral blood smear examination revealed abnormal RBCs leading to an accurate diagnosis. This is my last case. So 26-year female, fever, bleeding. Investigation showed anemia, thrombocytopenia, abnormal bleeding parameters. So we got a call from laboratory in charge, head of the department, at 2 a.m. in the morning about reporting the presence of abnormal promyelocytes on the peripheral blood smear. So provisional diagnosis was APML with coagulopathy. Immediately, the patient was started on ATRA, the definitive therapy for APML, same night after sending the pertinent the investigations. Subsequently, PML RARA was detected by RT-PCR, confirming our diagnosis. He completed therapy, now doing follow-ups with us. So acute promyelocytic leukemia, a hematological emergency, has a favorable outcomes with appropriate therapy. Prompt diagnosis and initiation of treatment were facilitated by peripheral blood smear examination and effective communication between laboratory and ward. It is always important. I am multiple times stressing on the communication between lab and the ward, which is very important. So now coming to the take-home message, blood cell staining was first done by Paul Ehrlich, 1878. Manual and automated peripheral blood smears are complementary to each other. They can't replace each other. Systemic examination of well-prepared and well-stained peripheral blood smear is required for detailed characterization of the blood cells. Staining, I have not discussed because Sangmesh has multiple times told me to follow the times. The PBS examination is incomplete without correlation with history, clinical examination, and other investigation. Good communication between the lab and the ward is key for better care. So these are few of the references which have used while preparing this presentation. And thank you for the patient listening.
Thank you very much, Dr. Vijay. It's a very elaborative lecture with very basics and important insights, which are covered almost all the different parameters which are to be there in the peripheral smear. In spite of all those new cell counters which are available in the market, the importance of peripheral smear still lies. It has a gold standard, and there are so many diagnoses that you have put forth on this lecture. There's so many diagnoses we can make only on the peripheral smear. Thank you very much. It's a very nice lecture.
Thank you, sir. Thank you. If there are any questions, if Sangmesh allows me.
Few questions we can take. One question.
No problem. No problem. Thank you. Thank you. Thank you.
Thank you, sir. I request our chairperson to kindly felicitate the Dr. Vijay Shirure, sir. I request Dr. Jayashree Pawale ma'am to kindly felicitate our chairperson. Now, moving to the next session, which is elaborated by Dr. Shashikant Apte, sir. Dr. Shashikant Apte, he is a well-known consultant hematologist. He started bone marrow transplant program in Pune and has done more than 1,000 bone marrow transplant till date. He is a member of executive committee of the Hemophilia Federation of India and a member of Thrombosis Task Force. He has n number of publications. So I request Dr. Shashikant Apte, sir.
कोणतं कसं येत नाही. Yes.
Good morning, everyone. At the outset, let me thank the organizers for inviting me to give this lecture on anemia. This was my first opportunity to put faces to the voices I have heard so many times. There are so many people I had spoken on phone, but I had never met personally. And that was a great pleasure, great honor for me to meet all you people in person. Anemia is one of the commonest symptoms and commonest manifestation of a disease pathology in human beings. Why we have to correct anemia? First, we must understand that anemia can be just a tip of an iceberg. It may represent something very sinister diagnosis in a given individual. So basically, anemia is an event, it is not a diagnosis. We have to diagnose what has caused anemia. The anemia is very prevalent in third world countries, and these are the published data about the snapshot of anemia in India. And this is a very scary thing that we are doing bone marrow transplants, we are doing CAR T cell therapies, we are doing severe immunological gene therapies, but we are still having people dying of anemia, getting undiagnosed and not being treated properly. So this is the burden of anemia worldwide, and the literature says that roughly 1 billion people at any given time are anemic. And it is not a problem of underdeveloped countries, but it's a global problem. So we have to think, and I always like to use his sculpture by Auguste Rodin, The Thinker. Anemia really puts your thinking abilities to the test, and you have to patiently sort it out with a stepwise approach. No one diagnostic tool can be paramount for the anemic evaluation. And it's a systematic process when we evaluate anemia. So when we are seeing a person with anemia, the question that arises in my mind, is it a congenital problem or is it an acquired problem? What could be the pathogenesis? Is it a production defect? Is it destruction, that is hemolysis? Or is it blood loss? And whether it is immunological or non-immune. And with these three basic parameters in my mind, I start taking the history taking. So in history itself will tell us whether it's a congenital problem or acquired problem, whether it's an acute problem or a chronic problem, because somebody says, I was absolutely fine, I donated blood 1 month back, and now you see him pale, something acutely has happened in last 3 to 4 weeks. That cannot be plain simple deficiency anemia. Something more sinister is happening, and that has led to the diagnosis of the event of anemia. Also, it's very important to ask for the history of recurrence of anemia. A recurrent anemia can have multifold diagnosis, but certain diagnoses, especially the malignant diagnosis, get ruled out if there is a recurrence. And these are the standard symptoms of anemia. That is, fatigue and tiredness is the commonest thing, and we ignore it. We have to keep in mind, even medical fraternity, there is definite increased incidence of iron deficiency and B12 deficiency states. So when we start evaluating, we have to look at the hemoglobin value, RBC indices. They should be rapid and reliable. That today's machinery has really made the job much easier than what we did 40, 50 years back. Using a Newbar chamber in pathology lab was a nightmare. All those nightmares are saved, and we have beautiful machines that have played an important role. These machines very rapidly give us the values, and these values, a well-calibrated machine is really complementary to the microscopy, as Dr. Vijay showed. We should be indebted to this gentleman called Wallace Coulter. Coulter was actually working on to pick up the impurities or contamination in petrol. And he realized by using this same principle, you can do the tests on hemoglobin in the human beings or animals. And this is the famous Coulter principle. And that is how the cells get measured. This is one of the prototype picture. You can see the hemoglobin is 13 grams. There is no anemia. But look at the RBC count. RBC count is 7.2. For 7.2 RBC count, hemoglobin is very low. So what has happened? There is a microcytosis and hypochromia. So there are small RBCs giving rise to the hemoglobin of 13.2 grams. And this was the picture. This is a bone marrow. So most important parameters in my mind when I see patient is MCV and MCH. Hemoglobin value is also important. But we know that we have both low, it will be microcytic hypochromic. Macrocytic MC will be high, but MCH will be normal, and it will be normochromic, normocytic if both are normal. This is the algorithm that really helps out. So one looks at MCV. If MCV is low, we are dealing with one of the hemoglobinopathies or iron deficiency anemia. If MCV is normal, that's the most challenging scenario when MCV is normal. But when MCV is high, we should look at the LDH. If LDH is also high, then we are probably dealing with megaloblastic anemia, or hemolytic anemias, or leukemias. Whereas high MCV, low LDH, or LDH is normal, we are most likely to be dealing with MDS, aplastic anemia, hypothyroidism, or again leukemia. These are the frequency of causes, and iron deficiency really hits the top of the list even in the global situation. That iron deficiency is the commonest cause of anemia globally. So how we can clinically classify anemias? We classify anemias as a production defect when there is a dietary problem or marrow disease. We call it a destructive problem, which can be immunological like autoimmune hemolytic anemia, or non-immune causes like malaria, can be TTP, and there will be associated significant jaundice when there is a hemolysis. Whereas when there is a loss, we have a lady, 35-year-old, coming with heavy menstrual flow. We really don't have to do a detailed workup. We have a cause. Treat that cause, give the replacement, person should settle down. If person doesn't settle down, a lady who comes with heavy flow, he has started correcting the hormonal issues, he has done the replacement therapy, but if there is no increment in hemoglobin, you have to relook into the patient and rule out the other causes. And these are the common causes of anemia in our community. Commonest is iron and B12 deficiency. B12 deficiency is many a times underdiagnosed. A lot of times, inadvertently, without doing the test, injection B12 is given and anemia settles down, and we never get the diagnosis why there was a B12 deficiency. So I'll elucidate some of the cases, and purposely I have done one thing, that I have kept the values same, but you can have the different diagnosis. You can have these values in any of the combinations. So first patient is 25-year-old patient with extreme fatigue, hemoglobin 8 gram, WBC 6,700, normal differential, and platelet 322. There is no organomegaly or lymphadenopathy. So what is the diagnosis? So when we did the hemogram, these are the values. And with these values, we have classic iron deficiency anemia, or a beta thalassemia, or a sideroblastic anemia, or a lead exposure. When we did the iron profiling, how to identify iron deficient person? It's an important issue. Iron deficiency and iron deficiency anemia are two different things. So we do serum ferritin, which is the gold standard after bone marrow test as the iron stores. We do total iron binding capacity, transferrin saturation, and serum iron. Hepcidin and protoporphyrins are not routinely available and not routinely done, but they are also the important parameters. So basically, when we do iron profiling, which is a term not used very commonly, and unfortunately it's an irony for an iron. And this is the thing, if you do the compilation of these four basic tests, you can really get idea on majority of the situations. This is the algorithm I would follow. That with hemoglobin less than 12 grams, transferrin saturation less than 20, then you assess the parameters with ferritin. And majority of the times you will reach to the conclusion with this. It looks to be a busy slide, but don't worry, it is quite simple slide. Once you start using these algorithms, you really know it by heart. So a person coming with recurrent iron deficiency, you have to sort it out. And most important test here would be in a recurrent iron deficiency anemia who has been compliant with the therapy or who has received IV iron and still has anemia, really needs to have an endoscopic evaluation. We had a 24-year-old nun working in one of the churches with decent dietary history, had iron deficiency anemia. Iron would not get corrected. She was asymptomatic. After 6 weeks, when there was no increment, we did the endoscopy and she turned out to have a CA colon at age of 24. It was not picked up initially. The stool occult blood may be negative. You need around 10 ml of blood per day to get melena or to get stool blood picked up in the stool. If it is less than that, you may miss it out. So if you have a persistent low hemoglobin, low RBC, low MCV, low MCG, and low MCHC, more likely it's to be iron deficiency anemia. Whereas in beta thal trait, you will have normal or high RBCs. And in HB electrophoresis, raised A2 is the hallmark of beta thalassemia minor. But let me tell you, even alpha thalassemia is not uncommon. We do miss alpha thalassemia because we are routinely not asking the investigation for alpha thalassemia. Because the patients are fairly asymptomatic and mostly we need a genetic testing to pick up alpha thalassemia because supravital stains, hemoglobin H preparation may not be positive every time. This rule of 3 is a very simple rule which I really like it, that RBC count into 3 should be equal to hemoglobin and hemoglobin into 3 should be equal to hematocrit. So the first printout which I showed, RBC count was 7. So hemoglobin should have been 21. But the hemoglobin was only 13 because it was a case of beta thal minor. So there is another patient now, 45-year-old patient with fatigue, same values, same parameters, and this is the PBS. This is the PBS. These rings can be seen in B12 deficiency, which with high MCV, can be MDS or liver pathology, or could be autoimmune hemolytic anemia, which is resolving. Upper GI gastroenteroscopy was done and it was positive for H. pylori. Believe me, H. pylori is very, very common in our country. And whenever you do upper GI endoscopy, please ask endoscopists to set up the test for H. pylori because it is one of the very easily treatable causes of deficiency anemias. Now, a 24-year-old man comes with the same symptoms, same values. But this time there is a mild splenomegaly and mild icterus. There is no lymphadenopathy. So Dr. Vijay had shown these PBS. We look for polychromasia. We do direct Coombs, retic count is high and LDH is high, and we have a diagnosis of hereditary spherocytosis. DCT was 1+ positive. But when we went through the old reports, even at age of 8, 10, he had hemoglobin values of 8 grams, 10 grams. So it was not an acute problem. It was a chronic problem. And we did the membrane studies and it confirmed the diagnosis of hereditary spherocytosis. This is the patient coming with, again, similar values, mild icterus. But this time there is a history of bone pains, and which is relieved after painkillers. There was a family history of bone pains and anemia. So on history itself, we can pick up or think of a disease like sickle cell anemia. History is very important because there are family members with similar history, similar presentation, looks to be something hereditary or a constitution or a genetic cause, and it confirmed sickle cell disease. Now this is a gentleman with intense icterus and brown urine. Retic count is 22 and G6PD values were repeated after the retic count settled down. You should never repeat the G6PD values or G6PD testing with high retic count. If you want to do, you can collect the sample, leave it in the refrigerator for 72 hours, let all reticulocytes in the tube mature, and then do the assay, G6PD assay. But if you do the G6PD assay on a fresh sample with high retic count, you will miss the diagnosis of G6PD because retics, even in G6PD deficient person, the values are normal. So basically, we have to hydrate the person. If required, we have to uh, give the blood transfusion, and blood transfusion is to be indicated by the clinical scenario and not by the value. So this is the situation where DCT is negative, ICT is negative, LDH is raised, low haptoglobulin and raised retic count with the situation. Now we have a gentleman with same values but MCV 91, MCH, MCHC normal and RBC count on the lower side. So we have normal iron, we have normal B12 folate, we have normal electrophoresis. There is no GI blood loss. We would go to the bone marrow examination. And bone marrow examination showed pure red cell aplasia, or it could be MDSRA. And we have tests like cytogenetics, we have tests like new generation sequencing to elucidate these kind of situations, because treatment is completely different. They may be the candidates for allogenic stem cell transplant and may need monitoring for evolution to acute leukemias. We also look for thymoma. Sometimes thymoma can present with PRCA. Sometimes PRCA may respond, it can be pure autoimmune and may respond to IV immunoglobulin. But there is a thin line between PRCA and MDS-RA. Sometimes at the beginning, you may have erythroid hypoplasia in MDS and it may get labeled as MDS-RA. So it is important to do all the tests. You may have to do PET scan to rule out lymphomas, because rarely lymphomas can cause PRCA, and these are the treatable causes of PRCA. Now same values, but MCV is 101. Normal MCH, normal MCHC, RBC count is low. There is no organomegaly. And this is the PBS, and this is fairly diagnostic of dysplasia. The marrow examination was done. The person had received large doses of vitamin B6, and the bone marrow showed sideroblastic anemia. The sideroblasts were seen in bone marrow. So high MCV, borderline anemia can be sideroblastic anemia, and you have tests to confirm it. We do cytogenetics, if we see 5q deletion, that group of patients really respond well to lenalidomide kind of a drug. But sometimes they may not respond and hemoglobin may keep dropping and could be the candidates for further aggressive therapies. The risk assessment is very important. Many times patients feel, I have presented with simple 8 gram hemoglobin, why doctor is doing so many tests? But there is a reason that not everybody undergoes all these kind of tests. But when you want to diagnose it and correct advice, you have to come to a conclusion. Because otherwise, you can't counsel the family or treat the patient. So when to do a bone marrow test for evaluation of anemia? So you have got no answers from blood tests. We try to confirm a suspicion. We have a refractory anemia. Please understand, a person which is non-compliant to oral treatment, a deficiency anemia is never refractory anemia. Refractory anemia is a proper noun. It is a name to the given entity. It is not a loose term to be used as a anemia not responding. That is not refractory anemia. There can be granulomas, there can be metastasis, and there can be malignancy. Above age of 60, we can pick up mild presentation can be just anemia, and on workup you may pick up to have a lymphoma, you may pick up to have multiple myeloma, and pick up to have anything. This is a classic tuberculosis disease, biliary tuberculosis with tuberculoma in the marrow, presenting as plain simple anemia. Then there can be aggregates of lymphoid cells. A low-grade lymphoma may manifest only as anemia, may have normal WBC count. may have normal platelet count, but you do a marrow and you pick up a disease like lymphoma. A lot of people are scared of doing marrows. Marrow is fairly non-invasive, painful test. It is not invasive test. It is painful, I agree. But there are various ways, and now with today's better needles, definitely the pain component has come down. And sometimes you may pick up secondaries. And these patients will need a further detailed evaluation what sort of secondaries we are dealing with. We had a gentleman who had multiple myeloma, who underwent a chemotherapy protocol, underwent transplant, and post-transplant, suddenly he started having a need for blood transfusion. Myeloma biochemistry and marrow done 3 months earlier was completely in remission. PET CT scan was normal. So why anemia? All tests had come negative. We repeated a marrow and we found large granular lymphocytic disease. And we treated it with steroids and cyclophosphamide. And his 1 year post treatment is complete remission for anemia. And also myeloma is in remission. A lot of times people ask me, what are the indications for parenteral ion therapy? I strongly feel that parenteral ion therapy should be really used when there is intolerance. Patient cannot tolerate iron. You can try various molecules, you can try various timings, but if the person is not tolerating iron, we have to really assort to IV iron therapy. When the needs are relatively acute, when suddenly in third trimester we realize that serum iron ferritin is very low and lady is now nearly 30, 31 weeks pregnant and she has come for the first follow-up, then we don't have enough time to give replacement to come to the term. So there I would use IV iron. But somebody who is in 10th week of pregnancy, has 8 gram hemoglobin, low ferritin, I really don't think there is an indication to give IV iron. If there is an intolerance, yes, that's an independent indication. And iron deficiency with persistent GI blood loss, we may have to give IV iron. We cannot compete the GI blood loss with oral iron replacement. So to summarize my talk, I would say that we have to take a detailed history when we see the patient for the same first time. We have to have proper counter report and PBS examination. We need a proper replacement therapy. We have to treat the underlying cause. And we have to have a judicious use of transfusions. 4 gram hemoglobin in 20-year-old female who is having chronic anemia is not an indication to give blood transfusion. Severe iron deficiency anemia, if person is stable, there is no tachycardia, no CNS symptoms, person is young person, we can definitely afford to wait, and we should not try to treat the hemoglobin value, but we should treat the individual sitting in front of us. If the person is stable, young fellow, I would definitely avoid blood transfusion. But yes, a 75-year-old man comes with 4 gram hemoglobin, pulse rate of 140, is complaining of palpitations. Definitely I would stabilize him by giving transfusion. But before giving transfusion, I'll collect enough pre-transfusion sample. Because pre-transfusion samples are most important samples to evaluate anemia. We have to have a judicious outcome assessment. Don't give the therapy and call patient after 6 months. Review the patient after 6 weeks. Make sure that the parameters are changing. Patient is improving. Because at 6 weeks, there is no improvement in hemoglobin value or the rise in retic count, I would re-evaluate the patient. And we may have to use bone marrow tests to evaluate anemia. With all these tests done satisfactorily, still there could be some patients where you may not find a cause immediately and you may have to do the repeat testing, and it can be very irritating for the patient as well as for the physician. But once you take a call, you have a healthy David cured of anemia and living life peacefully and enjoying himself. Thanks for your kind attention.
Thank you so much, sir.
Thank you, sir, for your elaborative lecture on
Thank you.
anemia. You have simplified the approach to anemia. It will be definitely be beneficial to all the pathologists sitting over here, and they will have a proper treatment protocol also for that. Thank you, sir.
Just for the audience, I'm leaving my presentation with the organizers. I'm quite happy for you to take it with you home. Thank you. Yeah.
Hello.
Yeah.
Sir, good morning, sir. Before a patient comes to a clinician, then to a pathologist for his examination, he's been treated by the local doctors.
That is
Most of the
fine.
times. Does that treatment change the clinical pathological picture of the smear, or
That depends. That depends. Suppose a person has B12 deficiency and without doing any test, sometimes you see knuckle pigmentation,
that's the
you just have a
even
hemogram.
for any clinical anemia
Yeah.
to be diagnosed, does you need a fresh start picture blood sample, or sometimes patient, or many times patient is been treated?
Yeah.
Then
So
how
many
do
times
you-
we do see patients coming with an outside report.
Yes, sir.
But somebody has asked for the report, because no person, if feeling unwell, will go to the pathologist first.
Yes,
He will
sir.
go to some
Yeah,
clinical
and
person.
even to a clinician, he comes treated by at a village level or at a
Sure.
primary health center level, taluka level.
Sure.
So does that treatment changes the picture?
Correct. It can change the diagnosis, or it can change the picture, because somebody without further evaluation has been given iron and B12. But after 4 weeks, you again see there is a drop in hemoglobin. Patient comes to us. If the person has received injectable B12, I never do B12 levels, because one injection of B12 will push up the levels. But we document that the patient has received injectable B12. Plus, a patient is on oral iron therapy, and we find that, say, ferritin is 150. Obviously, this is not iron deficiency anemia, because obviously ferritin cannot go to 150 with 4 weeks of oral iron therapy. For suppose the person was iron deficient, there would be a hemoglobin rise, and most important, you repeat the test and see what has happened to the hemoglobin if person has received treatment outside. Say, like 4 weeks back, hemoglobin was 7 grams. MCB, MCH were slightly low. Somebody started on B12 and ferritin. After 4 weeks, the test done, hemoglobin has come down to 5 gram. That itself tells us that this cannot be B12 or iron deficiency anemia. And then we do the further testing. And that's why I said you need an intermittent assessment for checking the rise in hemoglobin. Because otherwise you may miss a diagnosis like leukemia. Like first time he goes, hemoglobin may be 8 gram, WBC normal, platelet count 1,30,000, which is borderline low. After 2 weeks or 3 weeks, hemoglobin is 5 gram, WBC count is 40,000, and platelet count 20,000. 99% this is going to be acute leukemia. So it does change, but we have to re-evaluate. Thank you for your kind attention.
Any other questions from the audience?
Thank you, sir.
Thank you. Thank you.
Such a nice, informative lecture.
Thank you.
I request our chairperson to kindly felicitate the Dr. Shashikant Apte, sir. Now I request Dr. Sunil Swami, sir, to kindly felicitate the chairpersons.
So first of all, as Dantakari madam also said, your lecture was so lucid that it has made anemia simpler for even the pathologists who are actually supposed to be telling the clinician what the type of anemia is. And secondly, sir, since you are such an expert on bone marrow transplant, from your experience, I would like to know which are the cases where the bone marrow transplant really helps for a long-term good prognosis in adults as well as in pediatrics.
Bone marrow transplant for hemopiotic condition is a great tool. Like thalassemia, beta thalassemia major, if done early below age of 2 years, if you can do the full match transplant, cure rate is above 90%.
Wow.
Thalassemia is a great indication in pediatrics to do the transplant. Second group of genetic conditions is primary immune deficiency. Primary immune deficiency conditions like Viscott-Aldrich, severe combined immune deficiency, with early bone marrow transplant cure rates are high. The problem comes with these immune deficiencies, they present with recurrent infection. So many times we have to take them with infection on board, and that slightly changes the situation. Ultimately, leukemias, high-risk leukemias or relapsed leukemias, whether it's adult or pediatrics, bone marrow transplant is an excellent tool. Now the tools for lymphatic leukemias, lymphomas, CAR T cell is coming up, and I'm sure Dr. Samir will elucidate about the future of hematology. But a lot of these bone marrow failure situations, like aplastic anemia in adults, or a diamond blackfan or Fanconi anemia in pediatric group, they are completely curable. Their cure rate is not 100%, but some of the conditions, as I said about THAL, cure rate is crossing 90% if done early.
So, and what would be the approximate cost? Because I mean, we see so many of the thalassemia patients, like 20 years, they are just taking transfusions. I mean, I have a friend who's in charge of the blood bank at Thane, and she has some kids, like she's really looked after them for 20 years plus, and now the kids have gone on to even become engineers and all. But that's not the situation every time. So, if you, as you're saying, the prognosis is really good with a 90%, improvement in 90% cases, then I think it should be made more affordable and people need to know more about this.
Sure. If you do the transplant early, say the child is below 2 years, weight is around 12 to 15 kilos, not received beyond 20 transfusions, because by age of 2 years, 24 months, roughly 18 to 20 transfusions would be over. In this situation, cost of transplant would roughly come to 15 to 16 lakhs if it's a complete family HLA match donor. A family HLA match donor cost would roughly come to 16 to 17 lakhs at, or 15 to 17 lakhs up to the age of 2 years. If you take the cells from unrelated donor registry, the cost gets added up by 7 to 8 lakhs, because the registry charges if it's an Indian registry. If it's a German registry, the charges are similar like Indian registry. But European registries, they would roughly charge 20 to 25 lakhs just to give you the cells. And American registries would cost somewhere around 45 lakhs. So family HLA match donor, the transplant is much easier, much at a lower cost. And for thalassemia now, a lot of funding is available.
Yeah.
A lot of agencies are funding thalassemia
That's
transplants.
Thank you very much, sir.
Yes, sir, thank you very much. Proceed to the next lecture.
He's already head of department at Sri Markandeya Sarkari Hematology Latur. He has
Steps. To chair the session, I would like to invite Dr. Shiv Prasad Mundra sir, who is the professor and head Department of Pediatric at VDGMC Latur, and Dr. Sheila Kulkarni madam. She is the professor and head Department of Pathology at MIMSR Medical College, Latur.
Good morning, everyone. Indeed, a great pleasure to be here in Latur. We never imagined to be in a smart cinema hall, discussing and listening to stalwarts in the field of hematology and oncology alike. So I congratulate Dr. Umesh Kanade and his entire Latur team for such a wonderful show. Now, my lecture is in continuation with the first lecture, that is peripheral blood smear examination, and how important it is to have a careful review of peripheral smear. So that solves most of the diagnostic dilemmas. And if it does not, then one has to resort to a bone marrow study. Now, I wish to discuss this topic, starting with some basics like bone marrow structure. I won't go into a textbook details, but give you some relevant inputs. Then indications for aspiration and bone marrow biopsy, and a word about aspiration versus biopsy, which one is better. Some technical aspects of bone marrow collections, processing, and then we move on. As the time permits, we'll proceed with the cases. Firstly, the structure of bone marrow, as you are all aware, that it has two elements, cellular element and the stromal elements. And stromal elements are equally important as cellular elements, that one has to understand, because there is critical interaction happening between the cells and the milieu or the microenvironment of the bone marrow. Now, as you're all aware, right from UG days, we have been facing this question as to when does this bone marrow hematopoiesis starts. So in the embryonal till third week, it's in the yolk sac, and up to third month's liver, and in the fourth month, bone marrow takes over till childhood, and in adults and above, the almost all the bones and the flat bones have marrow within them. And sternum and pelvis are the two concern areas which wherein we deal with for bone marrow collections. Now it has been called as a cornerstone of hematology practice, because the bone marrow aspirations have been done thousands and in lakhs in numbers, but it's the bone marrow biopsy which has revolutionized the entire bone marrow scenario. So needle aspirations define bone marrow biopsies. Initially, why aspirations were done? Because they were easy to perform, they were very simple, and patients used to accept it easily. And indeed, for the pathologist or hematopathologist who was behind the microscope, it was very easy to read the marrow slides and interpret. But with the introduction of bone marrow biopsy and biopsy needles, as Dr. Shashi Apte said, these days it has become very easy to obtain the bone marrow biopsy. So bone marrow aspiration and biopsy both are complementary procedures to each other. Now aspirations are going down, aspirations and biopsies are on the verge of increase, and rightly so. Why? We'll discuss further. Now these are the various sites of uh, bone marrow biopsy and aspirations: posterior iliac spine and tibial tuberosity in pediatric population may normally take up the marrow. In adults, aspirations only can be done better with the manubrium sternum. But posterior superior iliac spine is the most preferred area. And why posterior superior iliac spine? For the reasons that it has a very large marrow containing area. And secondly, I just added it, patient can't see what you are doing. So even if you are technically, say, beginner, and you're a bit concerned, and especially if it's your earlier aspirate, the patient does not see your face, and you do not see patient's face, so you can just get along. Of course, that's not the only reason. The advantage is with the disease processes, we may have to conduct two procedures at a time, and that can be easily done if you are choosing posterior superior iliac spine. In obese patients, of course, you may have to resort to anterior superior iliac spine. Sternum is not recommended for bone marrow biopsy for the reasons you know, because of its close vicinity of the major vessels. Now, indications are myriad. Bone marrow aspirations and bone marrow biopsies. The indications, the list is ever increasing. sometimes we see a patient of anemia being advocated bone marrow as a routine, but that's not the right practice. So for red cell disorders characterized by when you're not able to classify the anemia on routine investigations, yes, that's an indication. The anemia that is not responding to the therapy, or if it is a refractory anemia, we may have to resort to bone marrow. Similarly, for leukocyte disorders, if the peripheral blood smear does not reveal any immature cells or blastic cells, and of course, overt acute leukemias, unexplained leukopenias or marked leukocytosis, and if you get atypical cells in the bone marrow, you may have to resort to bone marrow aspiration. Then in addition to that, megakaryocytic platelet disorders, low platelets or very high platelets, again it's an indication for bone marrow aspirations. Myeloproliferative disorders, you have to have bone marrow coupled with bone marrow biopsy. Myelodysplastic syndrome, yes, it's very important to have a bone marrow biopsy. Paraproteins, plasma cell dyscrasias, you need. Then in addition to this, some infections which can be picked up. And more importantly, these days, marrows are advised more often for evaluation of pyrexia of unknown origin. When you're not finding any cause on routine bacteriological and serological testing or the routine blood counts, you may be in with a surprise when you may get a diagnosis on bone marrow biopsies. And of course, for bone marrow transplant, you have to obtain the bone marrow. Bone marrow biopsy indications wherein the aspirates do not give you information, that's the indication that you have to resort to bone marrow biopsy in a single word. But in addition, the exact cellularity, if you want to assess with the bone marrow aspirates, won't be the right thing to assess the cellularity. So in that case, you may have to resort to bone marrow biopsies because you have to resort only to biopsy. There is no other way to assess the bone marrow cellularity. And if you're suspecting some focal lesions in the bone marrow, like fibrosis or maybe tuberculosis or some metastatic deposits, they cannot be picked up on bone marrow aspirates. Biopsy is a must. Then in aplastic anemias, hypoplastic anemias, myelodysplastic syndromes, hypoplastic acute leukemia, you cannot do without a bone marrow biopsy with some support advanced studies. Then in cases of Hodgkin's disease, to stage, in non-Hodgkin's lymphoma also to stage, one may have to resort to bone marrow biopsy. And as I told you, PO evaluation and some rarer disorders like amyloid deposits, some metabolic disorders of the bone or some other metabolic disorders, you may have to resort to bone marrow biopsy. Now coming to the technique, the needles, as you're all aware, pathologists and the clinicians used to perform, or still they do perform with this Salah needle, which is on the left. One that comes in various numbers, various gauges for various age groups, and it has a guard. And on the right hand side, you can see the modern day bone marrow biopsy needle with various parts, the trocar, the cannula, the biopsy pickup probe, etc. Now, why these needles are more being utilized more? Because they are costly, no doubt, but they are very, very sharp and they yield good biopsy. And there is no need to sterilize. For each patient, you have to get a new needle in. But with our experience, we observed that with this new generation refined biopsy needles, the biopsy procedures have become very easy for the person who is performing the biopsy and also well accepted by the patient. Now, once you obtain the bone marrow, how you proceed? This is a very important algorithm. Bone marrow के अभी आगे क्या करना है? You obtain 3 samples, 3 specimens when you are coupling bone marrow aspiration and biopsy. Aspirate, refine, and of course, importance of having imprint smear cannot be overemphasized. Why? I tell you. Aspirate is collected in anticoagulant containers, anticoagulant tubes like EDTA. Then the smears are prepared direct before putting it into anticoagulant, and you may get some clot. You may get some clot. We are not supposed to throw away this clot because that can be utilized as a biopsy. That can be processed and that can be studied. And that yields good information. Refined biopsy first has to be decalcified and then processed, and then you have to proceed with routine stents and special stents like HND, reticulin, and PAS and whatnot. Then imprint smears, as I told you, can be, they give you equal information given by the same information given by Trypan biopsy. So imprint smears are very, very important. Now this is on the left, you see the bone marrow aspirate. You can see the sinusoidal blood there with some particles of marrow which have to be separated from the sinusoidal blood to avoid the dilution effect and to assess the marrow morphology better. This one is a pediatric Trypan biopsy obtained from a 4-year-old boy. And this one is from the adult, this one. And see the way it has been placed on a slide. The very purpose for showing this slide is we have to have imprints. So once you take up the biopsy, you're not supposed to keep it directly into the formic acid formalin, but prepare some good imprints. And this is the way you prepare imprints. And on right hand side, if you see this two images, this one, this is the one which shows a lot many marrow fragments, and this is the one which is showing very few fragments, less fragments. This is all sinusoidal blood. So these are the areas which we choose for examination. These are the peripheral areas which will give you good information on the morphology of the cells. This side is again showing you the imprint, and this is the bone marrow biopsy section. Now, there have been a lot has been said yesterday when we had interesting slide discussion as to how we should be processing the biopsies. What we are doing is we are fixing the biopsy in 10% buffered formalin, and we employ some formic acid 10%, which we thought till that is the best sort of decalcifying agent, followed by paraffin embedding. But when I heard yesterday's interactive session, then I just visited the protocol as suggested by Dr. Gujral sir and Borges madam. I just took it down there yesterday, which tells you about the optimal processing of bone marrow defined biopsy, the Hammersmith protocol. And it indeed is very, very simple. And I'm going to follow this protocol henceforth. It is very simple. You have to obtain the biopsy and subject it to be fixatives like acetic acid, zinc, formalin, and they're decalcified in 10% formalin. And this, why this protocol is important? Because all the studies right from morphology, morphometric analysis to your fish, PCR, immunohistochemistry, everything is iterated, and that has been studied by Dr. K.N. Naresh. So our own person who has taken lead in formulating this protocol, this as not as an academic, but as a practical tool, one has to follow. Now, clot section, it is many times it such happens, those who are engaged in bone marrow aspirations and biopsy, you get many clots. And I already told you, you are not supposed to throw away these clots. You should always be keeping them in formalin, 10% formalin, and process as we process other biopsies. And as I told you, it's same information, because see, some focal disease processes like granulomas, like metastatic tumor deposits, some round cell tumor deposits can be trapped in those clots. And if they are not seen in the refined biopsies or aspirate, these clot sections can be of great value in picking up such lesions. Now, again, a $1 million question that is many times asked, why we should be doing aspirate only, or why we should be resorting to biopsies. See, bone marrow aspirations and bone marrow biopsies are complementary to each other, as I told you. Bone marrow biopsy gives you much better picture. Why? Because it tells you about the topography of the cellular elements, hematopoietic cells and abnormal cells. That topographic, their localization can always be assessed better in the bone marrow biopsy section. And in diseases like myelodysplastic syndromes, they can be very pivotal. They can be of great use to pick up those dysplasias. So also for say fibrosis, amyloid, gelatinous transformation, all this can be done. Then what is an adequate refined biopsy? Marrow biopsy, which is 1.1 centimeter, that's what the literature says. But you have to expect some 25% loss of tissue shrinkage. So in that case, 1.6 centimeter biopsy size would be ideal. In pediatric, of course, you have to have a 0.5 centimeter at least. And in terms of sections, 5 trabecular spaces at least, excluding the 2 subcortical spaces in the bone marrow section, is regarded as adequate. If it is below that, your job will be difficult and you won't be able to diagnose with sure. Then in certain conditions, you may have to resort to bilateral biopsies. If you have not obtained a biopsy in a single shot, the second biopsy can pick up the lesion. That is one concept. And secondly, the yield of your diagnostic yield will be better with bilateral biopsy. Now, as my previous speakers have overemphasized and emphasized rightly so, there are prerequisites unless and until you get good clinical backup, good clinical information with patient's domain, patient's clinical diagnosis, and what all laboratory investigations have been done. This interpretation of bone marrow aspirate and biopsy is very difficult. And this is something the person who is performing the marrow has to follow meticulously, that he has to maintain a record of all this. Now, these are all reports that all of you, I need not mention all the findings that you see in the bone marrow aspirate, which mentions about the points like the red cell count, the differential, then the erythropoiesis is differentiation, myelopoiesis, abnormal cells, etc., which all of you already know. Bone marrow biopsy report, just a word that you have to mention in the gross the length of biopsy. The architecture is very important, and you may have to do by default reticulin stain and immunohistochemistry as and when required. Concluding remarks with correlation with peripheral with bone marrow aspirate and further investigations to come to a conclusion. With this, we just move on to some interesting cases that we have encountered. Those will be, most of you will be able to pick those up. Let us go to case number 1. The 18-year-old male presented with fatigability, no organomegaly, no lymph nodes, HB of 6, WBC 2600, platelets 65,000, MCV 106, retics 0.2%, LDH 690. I think most of you must have picked it up. Yes, macrocytic anemia, right, with pancytopenia. What we do next, a peripheral smear review. On the left, you can see a beautiful hypersegmented neutrophil. And of course, on the left-hand side, this is the cell. Oval macrocyte and hypersegmented neutrophil is a feature. And this shows you the beautiful megaloblast. Now, the appearance of megaloblast in the bone marrow aspirates, we are so much used to that we hardly require bone marrow section to compare, but you need to see this. See, bone marrow megaloblast looks something like this. And this rest of the dark are the normblast or late normblast, and they have very peculiar linear membrane-bound nucleoli. And these look exactly like blastic cells. So this particular thing has to be borne in mind. And B12 in this case was very low. So this was a case of vitamin B12 deficiency anemia. Let us go to case number 2. A 67-year-old male who presented with generalized weakness. He had pallor, no organomegaly lymph nodes. pancytopenia, MCV 102 high, history of repeated blood transfusion. Just one, Dr. Apte sir had just mentioned about similar case. KFTs and all was normal and B12 was high. What this could be? I'll show you peripheral images. This is a peripheral blood film with reduced red cells, one giant platelets, rest of the platelets, no WBC seen in here. This side shows two abnormal WBCs with granular abnormalities and nuclear abnormalities, defective lobation, Pelger-Hue anomaly. And this bone marrow shows this fragmented nuclei of the red cell precursors with some abnormally shaped metamyelocytes. And this is a beautiful dyserythropoietic cell with dividing nucleus. And this is a bone marrow biopsy which shows a cellular, highly cellular marrow with, and this is a bone trabeculae and C, and you're getting clusters of megakaryocytes clinging to this on a cellular marrow setup with peripheral smear findings like that and the dyserythropic features. And of course, the stain, which is this stain? This is a Prussian blue stain for iron stores, and it shows, depicts beautiful ring sideroblast. So your diagnosis will be, or your impression, I don't use the word, we cannot diagnose myelodysplastic syndromes like that. You have to have confirmation by immunohistochemistry stains and of course cytogenetics. So this was MDS. Let us go to case number 3. 18-year-old female who presented with epistaxis, cutaneous bleed, blurring of vision, sudden onset, weakness, pancytopenia and severe anemia and prolonged prothrombin time. Our first speaker, Dr. Vijay, had mentioned about this is an emergency sort of scenario. Patient is bleeding with prolonged prothrombin time. So peripheral smear examination becomes very, very important, right? What does the peripheral smear say? It shows abnormal WBCs precursors, right? What are these cells? There is anemia, there is thrombocytopenia, and these immature cells, something hypergranular, right? Something here, again something here, right? And this is a blastic cell. What is this? Correct. So these are the book pictures of APML. You may not get these book pictures always. So it's very important. Most of the cases for second referral come to us because they are reported as neutrophils by some other people, and not every promyelocyte will look like this. But if you get these bilo cells with, of course, this kind of neutrophils, 3-part cell counters will count these as neutrophils, right? And this is again a picture with this cell is called as a faggot, right? With tons and tons of ore rods in the cytoplasm, beautifully depicted, prominent nucleolus, and the stacks of ore rods, right? And this is a bone marrow biopsy in this particular case because this was a peripheral smear diagnosis, right? APML is a peripheral smear diagnosis, but just to complete, we did the marrow, and this shows the cartilage cap with osseous trabeculae revealing highly cellular marrow, right? And this gives you this marrow is packed with promyelocytes. So why I said you have exact extent of cellularity can be assessed only with bone marrow biopsies. And these are all promyelocytes. You can even make out the aurora here in a tissue section. So what is the next test that you do in such cases? Correct. So we do fluorescence in situ hybridization or PCR for PML RARA because diagnosis is one thing, the treatment has to be instituted. As the hematologist said, it's a medical emergency. Even if you get a call for peripheral smear review in a suspected ABML, you have to do it. You can save one life. because PML RARA positive APML these days is a very has shown very good responses to ATRA, right? So this is regarded as APML is not regarded as acute myeloid leukemia, some authors say, and that's because it's a treatable and virtually curable condition these days. Case number 4, this has already been discussed yesterday. Just I will be giving you few insights, my views on this particular case. 35-year-old male who presented surgical OPD with anemia, pancytopenia, and massive PR bleeding was treated for hemorrhoids. And he had all those clinical signs of pallor and no organomegaly. And I want to draw your attention to this particular thing. This is a very common practice, right? Outside investigations done revealed hemoglobin of 6.5, WBC count of 2000 with normal differential, no comment on peripheral smear, cellular morphology, abnormal cells seen, and this CBC, his CBC was done daily basis for 10 to 15 days. And then the patient landed up with another clinician, and then CBC was done, and it showed HB of 4.6, 600 pancytopenia, and 2 blast, mind you. And this was reported as normochromic normocytic anemia with pancytopenia, immunoblast. Bone marrow studies were done. Other investigations, and this was the bone marrow picture, which is showing almost 60 to 70% plastic cell population. We did the biopsy, which revealed marrow packed with leukemic cells. And this was the impression. So this had given us morphological diagnosis, right? Subsequently, we went ahead with flow cytometry also. We sent the bone marrow sample, and it revealed a mixed phenotype acute leukemia. See, it all started with a normal differential count given by some unqualified people, and patient had this kind of very unusual leukemia. Why I'm stressing this here? Because I see so many clinicians, and role of pathologist comes here. A good pathologist will be able to pick up this condition, and that would go a long way in diagnosing the case and managing the case. With permission, just I will finish with one case if the chairpersons permit me, or I will just skip those. Right. I will show you some pictures, just bone marrow biopsy pictures. This is a 40-year-old female with presented with severe backache. She did not give, she gave vague history of some surgery being done, and she was illiterate, so she did not tell us what was the surgery. Neither we could retrieve that history, but she had anemia and pancytopenia. Indices were normal, and we did aspiration. Peripheral smear did not reveal immature cells. Bone marrow aspirate interestingly showed these kind of cells. This one. These are a few hematopoietic cells, but look at this one. They look foreign, right? They do not appear to be native hematopoietic cells. And indeed, we did the biopsy and we found that this patient had picture. What is this? A metastasis in bone marrow. This, and when she got back with the clinical details, which she was operated case of CA breast, that we got to know very late. And we then did hormone receptors. She was HER2 positive, but ER/PR negative breast carcinoma. Bone marrow biopsy again is a bone. Why I told you, just to highlight those, to support those views of mine. This is again a refined bone marrow biopsy. These are the osteostrabeculae. These are the osteocytes. You don't see any osteoblastic remain. What is this? This is a normo to hypercellular marrow with a pale zone in the center. And close inspection, what is this? Granuloma. So this is tuberculosis. Tuberculosis being so common, but yet there is no single diagnostic test. And so this can be picked up only with aspiration. Few more images like gelatinous transformation of the marrow can be picked up only on biopsies. Hypoplastic anemias or plastic anemias can be diagnosed only on refined bone marrow biopsy. So we come to the end of this talk. Maybe I will share all the slides with you all later. I really appreciate your patient listening. Hope my views on bone marrow biopsy, because I'm still, we started off with bone marrow biopsy some 8 to 10 years back. And every now and then we are getting good, interesting cases. And I thank organizers for providing me this opportunity to present our work. Thank you very much. Thank you for your patient listening.
Thank you, Poddar sir, for nice presentation. I have one basic question. We, as a pediatrician, our take-home message is that prefer bone marrow biopsy over aspiration. But now question arises, if when we do bone marrow aspiration, we send the slides to the lab. But what about biopsy? What we have to send and how we have to send?
So in pediatric age groups, it depends on the age. In fact, we have conducted few bone marrow biopsies at very small age, very early age. Indeed, it's very difficult to obtain a bone marrow biopsy in a pediatric age group. But still, the iliac crest is a good bone to get the biopsy, and we have conducted many on that. Tibial tuberosity also can be a good option.
Site
Yeah,
is okay.
tibial tuberosity
The
and
sample or the content which we collect.
that can be done. It is the same container as we use for all the tissue. You have to have some decalcifying chemical in the formalin.
Okay.
It should just, you have to take precaution that those bones are not heavily mineralized, so that formic acid proportion should be little altered.
Thank you.
That's all.
Thank you, sir.
Right.
Hello, good morning.
Good morning.
Thank you for your excellent coverage on bone marrow examination.
Thank you, madam.
Very useful, very informative. You have given excellent tip for preservation and fixation of bone marrow. And you made the bone marrow examination in a very simpler way. Thank you for sharing beautiful cases and images.
Thank you, madam. My pleasure.
Thank you, sir. Requesting the chairpersons to kindly felicitate Dr. Nilkant Poddar, sir. I request Dr. Abhijit Acharya, sir, to kindly felicitate the chairpersons.
To share his experience, Dr. Melody sir is a highly qualified and a now considered clinical neurologist practicing. He's also awarded with many awards. He has many
To chair this session, I would like to invite Dr. Vidyadhar Maske Patil, sir. He is a senior physician from Latur. I hope he is available in the house. Dr. Vidyadhar Maske, sir. Okay. Then Dr. Pragati Fulgirkar, madam. She is a senior associate professor from Department of Pathology, GMC, Sambhajinagar.
There is one request
Then-
to all delegates that all question and answer sessions will be taken at the end of all sessions. Ask me anything session. Please cooperate with us.
I request Dr. Vikas Solunke, sir. He is a senior associate professor, Department of Pediatrics at VDGMC Latur, to kindly chair the session. So it is a kind request for the speakers to maintain the timeline as we are running short of time.
This one. Second is. I'm starting direct from pen drive. Yes.
All right. Thank you to the organizers. एकतर मला सर्वात पहिल्यांदा आयुष्यात लातूरला आलो आणि 70 mm वरती PPT प्रेझेंट करण्याची पहिली संधी मिळालेली आहे. So I'm going to go very fast because it's a large topic and I've been warned that I have to finish it in time. Otherwise, this topic is something where I often overshoot, but I'll try to keep you as entertained as possible. So these are the branches and spectrum of hematology: transfusion medicine, malignant hematology, hemostasis, benign hematology, and diagnostic hematology. And we'll go one by one, a little bit of each. So coming first to transfusion medicine. So James Blundell was a British obstetrician who was credited with the first ever blood transfusion in history in the world, right? He made various instruments with which you could collect the blood and transfuse them. The problem was half his patients died after transfusion because they didn't know that there was anything called blood groups that time. In the United States, the first blood transfusion ever was given by the maverick surgeon William Halsted. You must have heard of Halsted's repair, etc. He was the first person who, his own sister was exsanguinating because of PPH. So he went over, he removed his own blood, transfused it into her, and then operated on her and saved her life. But it was only after Karl Landsteiner, who discovered the ABO blood typing, that actually, the blood transfusion became completely safe. And he won the Nobel Prize for this in 1930. And he, along with Weiner, discovered the RH system, after which, transfusions were really much safer. But then there was a problem of blood donation. It was a huge problem of blood donation because there were a lot of myths surrounding blood donation. And in India, particularly 50s and 60s, people are scared to donate. I'll give you an interesting story. This is the movie Amar Akbar Anthony, Aikla landmark scene in the history of blood transfusion, Amar Akbar Anthony. The scene is like this. The three brothers, they are Hindu, Muslim, and Christian. They don't know that they're brothers, and their mother, whom also they don't know that's their mother, meets with an accident and they happen to be around over there. And then they go and, in style, they said, Chalo mera khoon le lo. They donate their bloods. And look at this now. They are donating their blood. The blood is flowing anti-gravity into these bottles here. And from these bottles, 3 bottles, हे कुठून लाईन पाईप्स असे मी ऑलमोस्ट कपड्याला वाळत घालायचे तार जसे ना तसे अशा 3 तारी आहेत, and they are coming here. The blood is being mixed and the untested blood is going into the mother. Landsteiner would have had seizures in his grave. Okay, now when this movie was being done, the actors, they warned Manmohan Desai, the director, we are not going to go through such scientific nonsense. This is rubbish. You cannot go do this. But Manmohan Desai was adamant that this scene will not go from this movie. It will be there. And true enough, when this scene was played in the theaters, people used to cry and clap, But the fallout of this was that after this, there was, that time, the movies were very influential on people, on people's lives. There was a huge surge in the increase in blood transfusions all across the country. And to the extent that this was quoted in scientific journals. This is an international journal in which all international movies which showed blood transfusion, they were mentioned in this. And here the Amar Akbar Anthony also was mentioned. And so in another Asian Journal of Transfusion Medicine also, portrayal of blood and transfusion in Bollywood movies. And so what I want to say is that Manmohan Desai was the champion in this whole thing. So what I'm trying to say is that when you talk to lay people and when you talk to your patients, don't always be scientifically correct all the time. Talk in the language that they understand and try. You can even you're free to dramatize things a little bit, but just make sure that they get the point. Okay. Then there are these blood groups on the RBCs. We know. And this is the ABO system, and minor blood groups are there. We know this, and we know that the anti-A person who's got A has naturally occurring anti-B antibodies and vice versa. And we know that the 2 biggest problems with transfusion is mismatched blood transfusion and infections. So how can we mitigate this now in future, right? So this is the H antigen, which is the base on the RBCs. And over the H antigen, there is an A antigen and there is a B antigen. If you have both, you're called AB. If you have only one, you're called A or B. And if you don't have both, you're called O. But if you don't have H, you're called Bombay blood group, correct. So now what is being tried is, can you get enzymes that will cleave off only the A and the B from the H antigen and make everything into O, right? So this is being attempted since a long time. It surely will succeed in the next few years. So you can convert everything to blood group O so that it's universally safe to transfuse that kind of blood. And also pathogen inactivation of blood, in which you just take the blood, don't bother about what pathogen is there, add certain chemicals. 3 of them have already been tested and some of them are really good, but it's expensive right now. You add it, and then whatever germs are there in that will get destroyed. So the hypothetical future flow of blood in the bank will be collection, add pathogen inactivation compound, add enzymes to convert to blood group O, and issue blood for transfusion, right? Okay, so that was about blood transfusion. Then coming to cancer. So Hippocrates and Galen coined these words, oncos, and they had oncology, and they had a lot of wrong concepts about about cancer, of course, that time. But what was clear from their findings is that it is better not to operate a cancer, because operation causes more harm than good, is what they had thought that time. These were the fathers of hematologic blood cancers, right? So John Bennett and Rudolf Virchow, British and German, they gave the first accurate descriptions of microscopic findings of blood cancers, and they called Virchow coined the term leukemia. Anybody can identify these people? This is Sidney Farber and Yalla Pragada Subbarao. Anybody else knows about Yalla Subbarao? If you don't, it's a real shame. Sidney Farber was a physician at Harvard. He treated the first child with acute lymphoma. First ever chemotherapy to be delivered to a child in an attempt to cure the cancer was by Sidney Farber at Dana-Farber, which is at the Mass General Hospital. And Yalla Subbarao, MD Medicine from Madras Medical College, subsequently went into laboratory research in the US, and he was a biochemist. He discovered the metabolism of folic acid, and it is important in cell proliferation. And he discovered the first ever chemotherapy drug, which is methotrexate. And apart from this, he's credited with a lot of other things. He discovered phosphate metabolism, what is ATP. The concept ATP was driven by him, and he's got credited with many other drugs. And it is thought that unfortunately, most Indians also don't know him. He should have received at least 2 Nobel Prizes. So then coming to each individual blood cancer, I'm not going to go into detail. I'm just giving you a brief highlight about what is currently happening with these cancers. ALL became the first cancer to be cured with chemotherapy. Childhood ALL is cured in about more than 80% patients with chemotherapy alone. In adults, about 50% patients can be cured with chemotherapy. Other blood cancers can also be cured. In AML, roughly between 40 to 70% patients can be cured with chemotherapy alone. Lymphomas, about 40 to 70%, but in the vast majority of patients, it tends to recur back with just chemotherapy. Okay. Now, chemotherapy can be likened to crude weapons, trying to just kill whatever is coming in your way. Now we have slightly better chemotherapy, but still inadequate. And now, if you have a cancer which is not gone with chemotherapy, traditionally what we've been doing is you take an atom bomb, a missile, and just plant it inside the bone marrow, destroy whatever is there inside the bone marrow, and then replace it with somebody else's marrow, which will lead to the cure of the cancer, right? So this is bone marrow transplantation. The concept of bone marrow transplantation. And E. Donald Thomas was the person who performed the first ever bone marrow transplants in dogs initially, and followed by in actual humans, where he took the marrow from the human and infused it into the blood of the recipient. And he was given the Nobel Prize in 1990 for this discovery, along with Joseph Murray, who got it for the first organ transplantation, which is kidney transplantation. They both got it together. What's the bone marrow transplant scene in India currently? तुम्ही म्हणताल फारच फिल्मी लेक्चर चालू आहे. Anyway, this is a movie called Dard Ka Rishta, quite scientific as compared to Amar Akbar Anthony. This was a movie made by Sunil Dutt, right? You know that Sunil Dutt's wife had cancer. She died of cancer, and he was very passionate about the progress of cancer in India. Okay, so he made this movie in which it is shown that his wife, he's got a son and a daughter, and the daughter develops blood cancer, and the son is her donor. And how they Smita Patil, his wife, who is a hematologist, and she performs the bone marrow transplant. It is shown very scientifically. If it's available free on YouTube, you can show exactly how a transplant is done, right? And subsequently, movie was released in 1981. And in 1982, Tata Memorial Hospital performed the first bone marrow transplant in India, and that was triggered and pushed and fueled by Sunil Dutt. Okay, he actually bought he organized training. He bought the first cyclosporin and several other antibiotics for that patient who underwent the first bone marrow transplant. And subsequently, of course, CMC Vellore had performed the maximum transplants in India. Dinanath also, we've got almost now close to 700 transplants. And there are about 110 transplant centers recognized in India. And you can see the number of transplants has steadily been going upwards. And apart from just having matched sibling, HLA identical donors for bone marrow transplant, we now have matched unrelated donors, where you can find donors in the national and international registries, and you can just you can collect the samples from them. And now we've learned to transplant across HLA barriers also. So half HLA identical transplants, called haploidentical transplants, are now being performed with equal amounts. So you can see these are all the haploidentical transplants, and they're actually exceeding the number of bone marrow transplants of matched sibling transplants now. The commonest indication for transplant currently is acute myeloid leukemia and thalassemia, and then it's acute lymphoblastic leukemia, then bone marrow failures, the aplastic anemia, MDS, etc., and then the others are smaller indications, the rarer conditions. Now, if you problem with bone marrow transplant chemotherapy is collateral damage, right? Collateral damage. You give it, cancer may be cured, but too many side effects can happen. So now we want to look at targeted treatment, right? If you can find the exact target, how to, which you can hit, the whole demon can be destroyed, right? So we are in search of such a thing. Do you know who these gentlemen are? George Kohler and Caesar Milstein. They got the Nobel Prize in 1984 for discovering the first hybridoma technique for production of monoclonal antibodies. Right. So what is this hybridoma? I'll explain a little brief. So this is a mouse in which you inject an antigen which you want the mouse to produce antibodies against. Right. So the B lymphocytes from the mouse will start producing antibodies against that particular antigen. You then collect these B lymphocytes and fuse them. You want to immortalize them. So you collect myeloma cell lines. Okay, myeloma cells have plasma cells which have the phenomenal ability to secrete plasma cells over and above lymphocytes. So you fuse these plasma cells with the B lymphocytes, and that's called as a hybridoma. Right? And now you have a cell lineage which can produce infinite amount of antibodies, which you can collect and manufacture into a drug. So rituximab, etc., is all monoclonal antibodies. So the targeted therapy of cancer is monoclonal antibodies and something called small molecule inhibitors. What are these small molecules? Well, the first small molecule was imatinib, which came for the treatment of chronic myeloid leukemia. It's a small drug which can go and bind a specific target on a specific targeted cell which is known to cause the cancer and neutralize that cancer, inhibit this from working, and therefore you have the entire cancer comes under control. These are targeted drugs, and we know that dasatinib, nilotinib, ponatinib subsequently has come, and almost 80% or 90% of patients with CML now live a completely normal life, better than you and me sometimes. CLL, earlier only chemotherapy was available. Now you have targeted drugs, ibrutinib, acalabrutinib, which with just tablets, the entire disease is superior to chemotherapy. The entire disease can come under control. No need for any admission. So the immunotherapy of cancer is one, antibodies, which I described. Second, you can produce antibodies that make lymphocytes attack cancer cells, right? So so these are bispecific T cell engagers. And third is genetically modified T lymphocytes with better ability to kill tumor cells. So you can take lymphocytes. So T lymphocytes are the cells which have innate ability to kill the cancer cells, right? So, but the problem is that these T lymphocytes are often not able to bind to the cancer cell correctly, or they are not able to come close to that cancer cell properly, and therefore it cannot kill it. So what is done is, so one, you can, over and above an antibody, a regular monoclonal antibody, you can attach a chemotherapy drug to that antibody, right? So there's got a payload, like this is an antibody, it's got a payload. And these can bind the tumor, and selectively inside the tumor, the chemotherapy is delivered. These are called antibody drug conjugates. And these are they've made some phenomenal improvements in the treatment of cancer. The second is bispecific antibodies, in which you have an antibody like this. It's a chimeric antibody. One limb is able to bind to the cancer cell. One limb is able to bind to the lymphocyte, right? So it makes the T lymphocytes come in connection with in approximation with the cancer cell, and makes the T lymphocytes kill the cancer cells. And this is another phenomenal group of drugs. Blinatumomab used for treatment of ALL. This is the category of drugs that is coming up now. So acute myeloid leukemia, until now, chemotherapy forms the backbone of treatment, but two new drugs, azacitidine, venetoclax, which are again small molecular inhibitors, have revolutionized non-chemotherapy regimens with significantly low toxicity. And a combination of newer targeted oral tablets is going to come, and that is also going to revolutionize treatment of AML. Hodgkin's lymphoma, presently in early stage, 90% patients can be cured. Advanced stage, 75% patients can be cured. And here again, you have immunotherapy drugs, nivolumab, pembrolizumab, which have really revolutionized the treatment over and above chemotherapy alone. And almost 100% patients of early stage can now be cured if you add these drugs, and almost 95% with advanced stage. Non-Hodgkin's lymphomas, Burkitt's lymphoma has the highest incidence of cure, 90%. Hairy cell leukemia, again, highly curable, and most others have a range of cure between 50 to 70%. Multiple myeloma, a disease where nothing worked for over 2 years, is now one of the hotbeds of research for any blood cancer. And with a huge array of drugs that is now available, you can keep patients going for over 10 years easily with an excellent quality of life. Then coming to a concept called CAR T cell therapy. Must have heard of this, chimeric antigen receptor T cell therapy, in which what you can do is you can actually take physically these T lymphocytes and change their DNA in such a way that they are able to express a T cell receptor which can correctly bind to the tumor antigen. So you change the receptor which can bind to the antigen and thereby destroy it. So what is done in this treatment? Supposing you've got a patient who's got, say, a lymphoma, right? And his treatment with chemotherapy, his disease has not gone away. What you do is you harvest, you remove, with apheresis technique, you extract some of the patient's lymphocytes and you send them to a specialized lab. In the lab, what they do is that they take the T lymphocytes and they change their DNA. How is the DNA changed? You take a virus, typically a lentivirus, right? In the lentivirus, you take the gene which is with the T cell receptor. You make a gene for the T cell receptor which is able to correctly bind to the antigen, insert it inside the virus, right, and infect the virus with these T lymphocytes in the lab. So what happens is the virus goes in and imparts its DNA to the T lymphocytes DNA, and the T lymphocyte now can express the correct T cell receptor. These T lymphocytes are then expanded in the lab, and then they are collected and reinfused back into the patient. So these aggressive T lymphocytes will now bind to the tumor antigen, the entire lymphoma, and destroy it. Okay, and this treatment is now available, and it can be magical in some patients, although not in all patients, but it can be magical in and offer cure to patients with chemo-resistant cancers. Now, how is this? This all appears very science fiction, but it's actually true. This is the way it is done. So, how do you actually, cut, copy, paste the DNA? Right. So this is done with the system called the CRISPR-Cas9, which is the DNA scissors. This system can actually cut the parts of the DNA wherever you want, remove the dirty DNA, and then put in the correct DNA and make a completely new strand of DNA. So this is done by CRISPR-Cas9 technology. And CAR T cell therapy is now approved for the treatment of B cell ALL, refractory lymphomas, and multiple myeloma. So bone marrow transplant is a cure for these above diseases, but often bone marrow transplant fails if the load is very high or for other reasons. And CAR T cell therapy is much safer. The mortality is much lower, complication rate is much lower, and this can be a substitute sometimes to a bone marrow transplant. The present issue is that it is limited access. The cost is about 5 to 7 crores in the US, is about 1 crore in China and Israel. And India, we now have it available, and it is costing somewhere around 35 to 40 lakhs. And already more than 200 CAR T cell therapies have been performed in India already. Coming to hemostasis a little bit, this is the coagulation cascade, which you all kind of know about. I'm not going to go into in detail, but I just want to tell you that here you have factor 9, which activates 10 to 10A, and factor 8A is required as a cofactor which makes the 9 bind to the 10, right? So if you don't have any of these, you're going to have a condition called hemophilia. The problem with hemophilia is that you have to constantly give factor replacements which are intravenous, and it's very difficult to inject it constantly into children, which you have to give 2 to 3 times in a day sometimes. So that's very difficult and very expensive and very cumbersome. But now we have a bispecific antibody called emicizumab. This bispecific antibody has one limb which binds to factor 9 and one limb which binds to factor 10. So it completely bypasses the need for factor 8. You infuse this drug, it will bind 9 and bring it in approximation with 10. And this is the treatment for hemophilia now. And this drug can be given subcutaneously, and the dosing is just once a month. So it's a major relief and a major advance in the treatment of hemophilia. And now we have gene therapy available for hemophilia as well. This is gene therapy in hematology. Hemophilia A and B are curable with gene therapy, and so are sickle cell anemia and thalassemia. And how do you perform this gene therapy? In a similar manner, you take the gene of interest, you design a gene, the correct factor 8 genes, for example, insert it inside the virus, infect the virus with the cells that you want to, and you have a new cell that is you have new cells which express this factor now. So, for example, if you have hemophilia, the liver is the one which secretes the factors, right? So you infect you prepare the lentiviruses, infuse them inside the body. The lentiviruses go into the hepatocytes, bind to the cells that it needs to with a liver specific promoter, imparts its DNA to the liver cells, and the liver cells start secreting the normal factor 8. So this is actually working magically well. And now in India, Professor Alok Srivastava, who is our professor in CMC Vellore, has designed and he's prepared the first Indian gene therapy for hemophilia, which was published in the NEJM only a month ago. And this is actually something which is very, very exciting, because it was noted here that with US and Indian partnership, actually the reduced cost of gene therapy and a better access of gene therapy can now be offered. So this was for hemophilia. Similarly, for sickle cell anemia and thalassemia also, you can extract your hemopoietic stem cells, take them out, infect them with the lentivirus containing the corrected gene for hemoglobin, and then infuse these cells into the body back again after destroying your own recipient cells with chemotherapy. You infuse these cells again, and then you have hemopoiesis occurring from the newer transduced stem cells, with which you can have newer cells which are producing the correct hemoglobin. And that's how thalassemia and sickle cell anemia are now cured. Finally, coming to thrombosis, J. MacLean was a second-year MBBS student who, in the second year, extracted heparin from canine liver, and he made trials with this, and he discovered heparin, right, in the second MBBS itself. In the 1920s, cattle were found dead of hemorrhage in the prairies of North America, and this was called as a sweet clover disease. So they were dying when they were grazing through these fields. They were eating this particular plant, and they were found hemorrhaging and dying. And then researchers at this Wisconsin Alumni Research Foundation isolated a compound from this plant, which is called dicumarol, and they made it into a rat poison. And subsequently, this was again made into a drug called warfarin, which we now routinely use. And how does it work? It's a vitamin K antagonist. The directly acting anticoagulants are now there, which can, which are far safer and far better now in certain aspects to warfarin. You have dabigatran, you have apixaban, rivaroxaban, which are factor 2 or factor 10 inhibitors, and we safely use them nowadays. But now the latest drug that is going to come is factor 11 inhibitors, because factor 11 inhibitors have the least incidence of bleeding. Why? Because patients with factor 11 deficiency are found to have extremely good, even with severe deficiency, they don't bleed. So for some reason, if you inhibit factor 11, you can have a good anticoagulation but least incidence of bleeding, and this will soon become available. So finally, with diagnostic hematology, I'm just going to put one or two slides. This is Wallace Coulter and Paul Ehrlich. Already both these have been mentioned over here. Wallace Coulter discovered made the first blood counters, and Paul Ehrlich discovered staining of blood cells. And two important machines, flow cytometry, with which you can identify exactly what a particular cell is, with the kind of markers it expresses on the cell surface. You can identify what the cell is and therefore diagnose the different types of cancerous cells. And the next generation sequencing, wherein which you can identify the exact sequence and where the mistakes in the DNA have happened in a particular cell, and identify various genetic defects that define diseases. So with this, I come to the end of my lecture with these two statements from William Osler. Medicine is a science of uncertainty and an art of probability. Despite all these algorithms, etc., that is there, medicine is still an art. And scientific progress is measured in units of courage, not intelligence, because I believe that all these scientists were, of course, intelligent. You can't be a duffer and do this kind of work. But more than their intelligence, I think it is their courage that made them to do such things like, the bone marrow transplant that I mentioned, or so some of their discoveries, it probably requires more courage. So I thank you all for a patient listening.
Thank you, Dr. Samir. This is very complicated topic and recent advances in hematology, but you have covered all this in a simple, fast, and entertaining way. So, where do we get this all these treatment, recent treatment modalities in India?
These are all available routinely. I mean, of course, at higher hematology centers. So we have it in Pune. 3-4 centers in Pune have it, and also in other parts of the country they are available. So
Okay.
CAR T cell therapy also, of course, in only it is available only centers which are performing bone marrow transplants very routinely, because it is also certainly, I made it simple, but it's a little complicated, but it can very well be done. And most centers which have transplant facility and sort of the entire backup that is required for any for any major disease, in such centers it is available. So we
So
have
at
it, we do it routinely.
Pune, where is the center? Dinanath Mangeshkar?
Dinanath Mangeshkar, we do it routinely. Sayadri Hospital, it's available.
Okay.
And a couple of other hospitals as well.
Okay.
Jupiter, it's available.
Thank you.
Sir, what will be the cost for treatment of hemophilia?
What is the
Cost for treatment of hemophilia?
So
in
until
children?
now, it has always been factors, because factors were freely available. I mean, government has made factors available free. But gradually emicizumab is coming up. For factor 8, I'm saying it's gradually coming up and up, and it is overtaking regular factor replacement in many ways. And the gene therapy, whenever it comes, it's going to take some time. Currently, there are certain limitations because no pharma company is willing to take up the although we have the constructs ready, the drug is available, the whole concept is ready, but no company is still having the guts to take this up in a large fashion. Because it's easy for pharma companies to pick up a drug that is available internationally, just mimic it and use it. But this is a different concept completely, so they're not venturing into it yet. So gradually, it will build up.
Thank you, sir, for such nice presentation and in such humorous way.
Thank you.
Thank you, sir. I request our chairpersons to kindly felicitate Dr. Samir. I request Dr. Rahul Abange, sir, come forward.
त्यांनी घेतला.
I request Dr. Rahul Abange, sir, to felicitate our chairpersons. Continue with the next sessions. I hand over the mic to Dr. Sharyu and Dr. Khizra. Thank you.
कॉपी करतो ना बाहेर डायरेक्ट ओपन करू.
Good morning, everyone. Myself, Dr. Khizra Sadek. We look forward to hosting you for the next sessions. Please join me in welcoming Dr. Ruma Manchanda ma'am to chair this session. We have Dr. Pratima Somrani, professor from KBN Medical College, Gulbarga. She is the teaching faculty with the experience of 45 years. Second chairperson is Dr. Rajesh Patil, senior physician from the Latur. I would like to take a moment to address Dr. Ruma Manchanda, who have left an indelible mark on the field of hematopathology. Dr. Manchanda is Director of Pathology and Head of Hematopathology Department in prestigious Institute of KM Hospitals, Pune. Ma'am has hit the milestone in the field of hematology by starting the workup for the diagnosis of red cell membrane disorders, and also added the new test like CD34 to support the bone marrow transplant unit. Please give a warm welcome to Dr. Ruma Manchanda.
Thank you so much.
And thanks, Dr. Kanade and his team for inviting me to speak on a very dry subject. After Sameer's talk, my God, it's going to be very difficult for me to explain this dry topic of coagulation. But believe me, we cannot do without coagulation. Some basics I will quickly cover because the organizers said we are running short of time. So I will run through it, and so be patient and pay attention. Coagulation is basically involving clotting of blood, stopping of hemorrhage, and that involves three basic areas. If you see, it starts with the breach in the continuity of the blood vessel and contraction of the blood vessel, trying to stop that breach which is there. The platelets which are there now exposed to the underlying tissue, they try and go and sit there to try and plug that breach that is there. Meanwhile, what has happened is the plasma has come in contact with certain extraneous tissue factors, and this has what triggered the clotting factors. We will come to these factors in a little while. Now, what has happened to the platelets? They are sitting together, trying to clump together and plug that little gap that is there. This plug is trying to stop it, but it needs to be kept together. It needs to be kept to be wound with the wire-like thing, and that is the formation of a fibrin thread, which is formed from the activation of these clotting factors, in which thrombin is the main actor. We are sitting in a picture hall. So, coming to fibrinogen and fibrin, and that is how the fibrin clot is made. Not to forget, this clot has to be tightened. It is a very friable one, and factor 13 is the one which is the fibrin stabilizing factor. We are very aware of all these 13 factors which are circulating in the blood. These are all circulating as inactivated proteins, and they are activated in a very sequential manner as soon as the blood vessel is ruptured and exposed to the underlying collagen. Very age-old concept. Coagulation and how these factors are interacting. When I was a student, this was the only way we were explained, the extrinsic way and the intrinsic way of clotting, but could never understand how does the body decide कि हमको clotting इधर से करना है कि उधर से करना है. It was so difficult for us to understand. In 60s, I'm talking of, and in 70s, 80s, we got the newer concept. I will be discussing that. But fortunately for us, this is the concept which works in our laboratories. This is what is helping us in diagnosing all the clotting problems. Quickly, intrinsic, as it said, inside the body, with the contact factor, goes down through factor 10. On the other side, extrinsic, the tissue factor, coming with the tissue factor, factor 7 activated, coming to the common pathway 10, with 5, prothrombin, thrombin, activating fibrinogen to form fibrin. We have lots of fibrinogen in our body, and we need lot of thrombin formation so that it can be taken care of and form more and more clot. This fibrin clot is cross-linked, and factor 13 tightly उसमें गांठ बांध देता है, उसको एकदम tight कर देता है. This is the stabilizing factor, which is very, very important for a good quality of the clot. Now, that is the concept of classic coagulation cascade. However, physiologically, what is happening in the body, you can see factor 12 has run away. It has no work to do in the clotting inside the body. It is a contact factor. It is pre-kallikrein system. but not needed for routine coagulation of blood. So factor 13 has gone away. Tissue injury is the first trigger, and with the help of activated 7, this factor, tissue factor 7A, goes and activates 2 areas, 9 as well as factor 10, and then comes to form thrombin. This thrombin goes back to act on 11, which activates to 9 and comes back. So this circle continues so that more and more thrombin is formed and more fibrinogen is used to form a good clot. That is the physiology of coagulation cascade. Let's come to the approach. Now, a patient has come. The patient is bleeding. We need to know what is the reason for that. For that, we need to know who is our patient. What I mean by this is, how old is our patient? What is the problem of the patient? And what type of a bleeding does the patient have? So the approach has to be a complete detailed history. It's a multi-step evaluation, and we see the complete detailed history, thorough physical examination, and later on we come to the laboratory test. Clinically, we see that there are petechiae, purpura, or hemarthrosis, or hematomas. Each one is telling us that petechiae, purpura are the plate properties or the problems of platelets. Can be the platelet number or can be the platelet function. These hemarthrosis or deep hemorrhages are usually the deficit of one of the 13 coagulation factors, what we call coagulopathy. So to begin with, a clinical history is of prime importance. We want to know, is this happened today for the first time to the patient, or has this been happening since childhood, since birth to that patient? Family history helps us. Is there any family history of other bleeders or clotters in the family? So try and make a family tree if you can. Thorough clinical examination to look for organomegaly, lymphadenopathy, hepatosplenomegaly, because that points towards a secondary cause. It may not be the primary coagulopathy. Where is it bleeding from? Is it the right nostril every time? Well, look for the local reason. But if it is a complete hemostatic failure, then yes, it is something to do with the blood and one of these factors. How often do they bleed will also help you to categorize how much is the problem, how serious is the problem, and the level of the deficit of the factors. Is it spontaneous or is it on a stimulant, post-traumatic? What is the duration and does it need a transfusion support? Makes all the difference. As I said, this is petechiae, purpura, platelets, and the others are coagulation disorders. Please take a drug history, which is very important because these days everybody is taking lots of self-medication. Don't forget to ask for Ayurvedic, homeopathic, ginseng, some khane peene ka bhi. Please take the history, which is very, very important because all this has been said to contribute to the clotting of the blood. How do we do the screening coagulogram in my institute? We take all these tests. That is our first line test, what we call as the coagulogram. A screening coagulogram starts with CBC. I will cover this at the end, but coming to all these, what you see in red now is the one which is the property of the platelets, the platelet number and the platelet function. That means the bleeding episodes, morphology of the platelets, the retraction. All this is telling us about the problem in the platelet section of bleeding coagulation. The others, which are black, are all those 13 factors which are waiting to be activated and to form the clot. They are the ones which are related to the coagulation factors. How we report a complete screening coagulogram is this. That is our report. And with this, please remember the bottom line is absolutely necessary. If you give a clinician all these readings without your impression, what does it mean to you and to the patient? Convey it to the clinician. You have to put down an impression at the bottom regarding all those tests that have been illustrated. Okay, coming now to the coagulation test. We know that the basic coagulation test, everybody knows prothrombin time, APTT, and the thrombin time. I'll quickly discuss these. Prothrombin time, as we call PT, is tissue factor with factor 7. Now, tissue factor is provided by our reagents. All the reagents are there. They contain thromboplastin, and they are the ones which will trigger the clotting of this test. This test uses these reagents, but these reagents are very variable in their sensitivity. So one has to be very careful that if you are using a reagent in your laboratory, please do not go on changing your reagents, because some of your patients who are on anticoagulants are stabilized due to your one reagent history. We had a patient who traveled, who was very stable, aortic valve replacement, INR 3.5, went to visit her daughter. And एक महीने में जाके फिर से prothrombin time किया. Prothrombin time came 2. And that was one of the best laboratories in that area. So the mother said, okay, now I have to increase my dose because this is not what is desired in my case. Somebody told her, do not change your dose, because the reagent used by the daughter's place, that laboratory, was different sensitivity to the prothrombin time. And that is what we must understand. Please do your workup with the same test, especially if you have patients who are on anticoagulation, oral anticoagulation. Do not go on changing your reagents because they have different sensitivities. So prothrombin time, a normal one tells us that 7 is present, so is 10-5, prothrombin and fibrinogen. A normal prothrombin time is telling us only this much. We have surgeons whose pet pre-surgery write-up is BT-CT-PT. Stop. BT-CT-PT. Now BT is anyway being thrown out. So CT and PT. PT has done this, but what about these? What about these? Where are they? Surgeons still do not know. We have to educate them, tell the clinicians that BT-CT PT is incomplete coagulation parameters to assess the hemostasis of a patient. So prothrombin time normal is just telling us about this arm of coagulation. Coming to the APTT, which is activated. Why do we call it activated partial thromboplastin time? Because it needs an activator to start. Now, I told you the classic coagulation cascade in the laboratory when we are using these reagents is starting from factor 12. And factor 12 is a contact factor. It needs to be activated. For that, one of these activators are needed, and whatever reagent you are using will activate these except allergic acid, which does not activate 12. Now coming to partial thromboplastin. What do we mean by partial thromboplastin? Partial thromboplastin has only phospholipids. It does not have any tissue factor. And that is why it is called activated partial thromboplastin time. And different preparations of phospholipids are there from different origins. You can use any one of them, but these days, most of them, some are animal origin. The animal rights people are fighting. इनका क्यों ले रहे हो? Rabbits का thromboplastin क्यों ले रहे हो? You are killing the rabbits. Plus the supply. अभी इस मौसम में human placenta or rabbit बहुत quantity में मिल रहा है. But after 6 months, the quantity is much less. Demand and supply. So nowadays, recombinant reagents are being used with very standardized sort of sensitivity to all the factors. So coming to the APTT, as I said, depending on the amount of phospholipid in your reagent, it can be lupus sensitive or it can be factor sensitive. You have to decide what do you want in the lab. Normally in our lab, we have kept 2 reagents, factor sensitive, not to miss the factor deficiencies, and to have the lupus or inhibitor sensitive, another reagent. Ideally speaking, single reagent with sensitivity equal to both the sides should be chosen and should be used in any laboratory. So that is the area which is APTT. After activated, it goes down the common pathway and forms the clot. Look at the way it has to travel. It is a longer way to travel. That is why your APTT is 28 to 33 seconds, whereas your prothrombin time was 11 to 13 seconds. It was a quick pathway, short pathway. So that is the area where the clotting with the clot contact factor quickly goes down to form fibrin. And it is telling us that all the factors are present, all except 7 and 13. These are the only 2. If your APTT is normal, you are only worried about 7 because 13 is also out of the purview of these 2 tests. Fibrinogen to fibrin. That's all that thrombin time is doing. And it is needed whenever you have a APTT as well as PT prolonged. So you would like to know whether fibrinogen is there to form the clot or not. All these 3 together are taking care of all the clotting factors except factor 13, which is a serious bleeding disorder, especially in neonates and children. So any laboratory which is not looking for factor 13 by doing the urea solubility test is missing cases of factor 13 deficiency. Okay, a lot of issues in coagulation, one of the difficult tests in hematology. And this needs a lot of thought because there are a lot of pre-analytical, analytical, as well as post-analytical issues which are around this coagulation test. Let's look at this case. Now I'm coming to few cases and how we approach them. Look at this smoker. He's 54 years old and he's presented with headache and nosebleed. Hemoglobin is 21 with hematocrit of 64, normal platelets and WBCs. PT is normal. That means this arm of clotting is normal. However, his APTT is 48/28. How do we interpret this now? That is the big question because he is bleeding from the nose and has one of the tests which is little abnormal. But we cannot ignore the hematocrit because this is one of the pre-analyticals which we have to keep it in mind when you are interpreting your test. Normal collection is 1:9 for your sodium citrate collection. That means your 1 of citrate is anticoagulating this much plasma, not the RBCs. It is anticoagulating the plasma. If a person is polycythemic like this gentleman, his RBC mass is much more and his plasma is very little. We are adding the same amount of sodium citrate. We are diluting all his factors. So it is very important to recollect the sample. Now, same thing happens in babies. We all know, especially if you have a good neonatology unit, the baby's blood is usually this hemoglobin, 22, 21, with a high hematocrit. And there again, you will have the same kind of problem. Ask the mother to collect the blood again. She will come with a danda. She will never give another sample of a newborn baby. So to recollect a sample again, from an adult it is okay. But from a baby, if you ask, I'm sure nobody will give you again. So what is happening is that sodium citrate nowadays, the International Society recommends 3.2% sodium citrate with a ratio of 9:1. You can see when the patient is anemic, the PCV is so little and whole lot of plasma. You are under anticoagulating an anemic patient and creating false PTs and APTTs. So that is the ratio and the formula which has been put forward to adjust for the hematocrit. Higher the hematocrit, less amount of citrate, and more hematocrit, more plasma, you need more citrate. So that has been used in many places. Now coming to some cases, 4-year-old child, ecchymotic patches, passing blood in stool, has no fever, no other problem. But look at the coagulogram of this boy. He's got a clotting time which is prolonged. Prothrombin time is prolonged, but APTT is normal. Keep that diagram in front of you. If APTT is normal, it tells you that all the factors are present, except factor 7, which is out. You have a thrombin time, which is also normal. So look at the coagulation of this baby. Normal APTT in this child is telling us that 12 to fibrinogen, everything is there except one which is sitting outside, and that is prothrombin. And that is why this child has a prothrombin time which is prolonged and has a normal APTT. This is highly suggestive of factor 7 deficiency straight away. So it is isolated PT prolonged with a normal APTT. Next case, 2-year-old boy. Very easy bruising, hematomas on injury, but there is no family history of significance. Have a look at the coagulogram. Bleeding time is normal, clotting time is prolonged, prothrombin is normal. Prothrombin normal means 7, 10, 5, 2, and 1. Everything is present, but APTT is prolonged. APTT prolonged, look at this. Prothrombin is normal, which is telling us that all these factors are present. So look somewhere above 10. We know that factor 12 is not a bleeder. So that automatically goes out. We are left with only 3. We are left with 11, 9, and 8. And isolated APTT is usually intrinsic factor. And that is how we report it as an intrinsic factor deficiency. And we will ask for mixing studies so that we come to the conclusion whether 8, 9, or 11. All three are bleeders. 12 is not a bleeder. This gentleman, 78 years old, no previous history of any problem at all. He is the one who has now come with weight loss of 4 kgs in 4 months. Is bleeding gums, hematoma on the left side of the arm, off and on, but there has not been any previous history. Look at his coagulogram. He has APTT prolonged. Now, APTT prolonged in an elderly gentleman with no previous history, one will have to look at it carefully. It means there is an intrinsic factor deficiency. Do the mixing studies. What do we do in mixing studies? You take the normal plasma, mix it with patient's plasma. If there is a deficiency, the patient's defect is corrected. If not corrected, there is something inhibiting in the patient's plasma, which is not taking care of the result. APTT is not corrected. So we do the mixing studies to find out if there is factor deficiency or is there an inhibitor present in the patient's plasma. This patient did not correct. So there was no deficiency in this gentleman, but he had factor 8 level, which was about 5%. So he had an inhibitor which was probably to the factor 8. And these are called acquired hemophilias. How the mixing study is interpreted is given in the books. One can always refer to these. These acquired hemophilia are seen in autoimmune disorders, in malignancies, especially GI tract malignancy. So I think this gentleman should be worked up for the GI tract pathology. These are what are called acquired hemophilia with acquired hemophilia or inhibitors. The screening coagulogram of this now, this is a girl, sorry, this is a girl who's 11-year-old, 15-year-old girl, who's having easy bruisability and menorrhagia, bleeding gums, and has APTT prolonged, but more of bleeding tendency. Now, if you clinically have seen, then hemophilia normally does not have a bleeding tendency, but APTT prolonged, then you are thinking of probably a von Willebrand disease, which has a platelet function defect along with this. The case of 6-year-old child with epistaxis has both prolonged PT and APTT. Obviously, this is in the common pathway, which is happening in this area. And then you do again the mixing studies to find out whether it is factor 10 deficiency or do the factor 5 and the prothrombin estimation. This 35-year-old female post-delivery infective, very classical case, which has PT, APTT, thrombocytopenia, all problems everywhere, including thrombin time, which is prolonged. That means fibrinogen is also low. And this is what happens in cases of DIC, that is disseminated intravascular coagulation. This boy, fever, petechial rash of this kind, if you had not seen clinical picture, you will miss the diagnosis because his coagulation profile was bang normal. There was no problem at all in any of the screening coagulogram tests, but looking at the clinical picture, he is highly suggestive of allergic vasculitis or what is called Hinox-Schonlein purpura. They present like this with a normal coagulogram. 6-month-old baby, ecchymotic patches, no family history, and has a coagulogram like this, which is all these basic tests are normal, but the clot solubility test was the one which dissolved, telling us that there is factor 13 deficiency in this baby. Very important to understand that factor 13 is not part of your PT or APTT, and that is why you must do the urea solubility test if you want a complete coagulogram. Full-term baby, as I said, neonates have a higher hemoglobin, PT normal, APTT high. How do we interpret? We should know that clotting, the coagulation proteins, do not cross placenta. They differ markedly from adult levels. There is less than 70% of the value of these factors. Only 2 factors, 8 and 1 millibrand, are little on the higher side. That is the level in all the babies. When in the lab, you are collecting the baby sample and you are having a control, you don't have a baby control. You are comparing with an adult compare. Compare with an adult value. You don't have our, कोई बच्चा नहीं आएगा आपको अपना control sample देने को. So we have adult controls in the lab and you are comparing with the term baby and a preterm baby. This is normal for the term and the preterm babies. So while interpreting, you must pay attention and don't call any baby hemophiliac or any other inherited coagulation problem if you do not know the age and wait for some time. Last, significance of hemogram in the bleeding and clotting episodes. We can already been mentioned schistocytes, microangiopathic hemolytic anemia, spherocytes in immune hemolysis can cause immune coagulation problems. Eosinophilia in the sphere can tell you acquired platelet function defect with eosinophilia. If you have platelets like this in a fresh smear, it is Glanzmann's, more likely to be Glanzmann's thrombasthenia. If it is truly a fresh smear, looks like an EDTA smear. Glanzmann, these, if you have Dole bodies, can you see this blue body here in the neutrophil with giant platelets? Very rare, but a cause of concern. They have giant platelets. They have thrombocytopenia. They are from a group of disorder called MYH9 molecular defect. They look like ITP because there is thrombocytopenia, they bleed, and they have giant platelets. They are put on steroids, but they do not respond to steroids. So if you look at your smear carefully, you will miss MYH9 disorders if you've not looked for Dole bodies with giant platelets. It's very important to pay attention. That is why the coagulogram starts with hemogram. Look at all that and then come to your clotting factors. These are those disorders which are listed in MYH9 disorders, May, Heglin, Sebastian Fechner, and Epstein. They all have giant platelets and Dole bodies. So, coming to the end, you must know who is your patient, acquired or congenital. What are the pre-analyticals? How are you collecting? How it is collected, stored? Analytical, what reagents you are using? And interpretation, who is your patient? APTT of 40 and 50 in a newborn is absolutely normal. Points to remember. Lab tests have to be interpreted with caution. Do not change your laboratory on the time of the change the laboratory reagents in the lab. Gestational age, postnatal age, and vitamin K status must be given to you when you are interpreting a neonate. Inherited deficiency should be deferred by, they've said 1 month, I would say by 6 months, actually, the baby attains a proper level of all the clotting factors. And all this should be considered whenever you are doing or approaching or looking for diagnosis of a patient of coagulation problem. It is a problem. It gives you a lot of sweating because still, in spite of doing everything, you'll be surprised how many times we cannot come to any conclusion why the patient is still bleeding. Thank you so much.
Thank you so much, ma'am, for that enlightening talk packed with valuable insights of coagulation.
I request Dr. Pratima Somrani ma'am and Dr. Rajesh Patel sir to felicitate ma'am.
Thank you, organizers, for giving us this opportunity. It's a privilege and a proud moment for me to be chairing this session of my teacher indirectly because I've been listening to ma'am right throughout my undergraduate, my postgraduates, and my earlier career. Though I have not known her personally, but I have been following her lectures in most of the CMEs and conferences. She has made coagulation the intrinsic, the extrinsic, and the common pathway, which is a complex interactions, like a simple table of two, which any child can understand. Thank you, ma'am, for the lucid presentation. Thank you.
एंड अदर मीटिंग करू इथे एकच दिसतीये स्विच करू का
I request Dr. Saroj Khotale ma'am to felicitate the chairpersons.
I request all audience to give a standing ovation to Dr. Manchanda madam, please. In progress. Join her अर्चना meetings. Start. अरे 2 झाले थांब. Cancel.
Our next session will be of Dr. M.B. Agarwal sir, who is a distinguished expert in his field of hematology, and we are honored to have Dr. M.B. Agarwal sir to join us today for an online session.
I would like to take a moment
Switch करायचं
to
बर मग कसं जॉईन व्हायचं
गेस्ट म्हणून लॉगिन कर
गेस्ट म्हणून कुठं कसं करायचं एक मिनिट
I would like to take a moment to address our speaker, Dr. Mohan B. Agarwal, who is more popularly known as Dr. M.B. Agarwal, one of the reputed hematologists in the country. He is president of Mumbai Hematology Group and head of the Department of Hematology at the Bombay Hospital Institute of Medical Sciences, Mumbai, and also acting as a consultant hematologist at n number of hospitals in Mumbai.
857.
He has number of professional and academic achievements apart from receiving a number of awards. Dr. M.B. Agarwal sir definitely stands tall amongst the gala of all the hematologists. We are delighted to
join the online session of Dr. M.B. Agarwal sir, which will be started in just few minutes.
I request Dr. Arvind Bagate sir, Professor and Head of Amba Jogai sir, to chair the session, and Dr. Ashok Ganu sir, Senior Physician from the Latur, to chair the session.
एक मिनिट सरांना शेअर स्क्रीन झालं ना तिथून मेक होस्ट करावं लागेल सरांना झालं कसं करायचं
डबल क्लिक त्याला हे करून टाक मिनिमाइज करून
Is it okay? Everybody's comfortable? मी करू. Sir, are you audible?
Okay, can you hear me and can you see my slide?
हा त्यांना म्यूट हे करावं लागेल.
Can you hear me? Can you see my slide?
Unmute करावं लागेल त्यांना. नाही माझं नाही माझं आहे. सरांना कॉलच करावं लागेल.
Can you see me and can you see my slide?
Yes, sir.
You can hear me and you can see my slide, right?
Yes, sir. Yes, sir.
I'll start my talk. Okay. Should I start my talk?
Yes, sir. Yes, sir.
Okay. So, life without platelets. I thank Dr. Umesh Kanade, President IMA Latur branch, for this invitation. Platelets. Cinderella. There's a movie called Dust in the Blood about 70 years ago. And the platelets are like the dust particles in the blood. This is what they look like under an electron microscope. And this is what they look like under light microscope. You can appreciate their color, shape, size, and how do they clump. When they are deficient, you see just an occasional platelet in a film. Megakaryocyte is the mother cell, the largest cell in the bone marrow, which relentlessly keeps producing platelets for the whole life. Platelets are finally destroyed in the spleen and the rest of the reticular endothelial system. Platelets are important for the first phase of clotting. Whenever there is a cut in the skin or mucous membrane, platelets come there and seal that hole, and this is called primary hemostasis. Reasons for low platelets could be two groups: platelet destruction or inadequate production. Of course, there can be sometimes what is called sequestration in an enlarged spleen. When the platelets are being destroyed, then the platelets which are produced from the marrow are more. These platelets are young and they look large. On the other side, when the platelets are not being produced from the bone marrow, the platelets look small, as you see as the arrowhead in this slide. When you look at the platelet count and it is low, you look at two parameters: the mean platelet volume and the immature platelet fraction. Both of these help you in differentiating whether it's a production problem or it's a destruction problem. The platelets are being destroyed, then as the large platelets suggest, both MPV and IPF will be raised. There's a term called reticulated platelets. Most of the cell counters may not have this facility, but you have this, then the reticulated platelets signify that the production is good. What happens in the clinical practice when the platelets are not there? A simple undergraduate teaching is that you get purpuric spots on the skin and you can bleed from any mucous membrane. Very few people realize the deficiency of platelets lead to extreme fatigue, and that can be very unnerving to the patient. And lastly, as a paradox, deficiency of platelet can produce thrombosis, especially of the venous system. Platelets are also immunocytes. They protect you against infection. Therefore, any infection, the platelets go up, and when they are consumed, they go down. This is an electron microscopic picture once again to show you how platelets engulf the organisms and destroy them, just like neutrophils, monocytes, lymphocytes. Platelets have a great role to play in inflammation. So if you have disorders characterized by inflammation like rheumatoid arthritis, there may be increased platelet count because they are inflammatory cells. Like any other disease, history is an important aspect to come to a diagnosis. For example, this particular person has got bruises on the back. These bruises are running parallel to the ribs. Investigations did not show anything wrong with the coagulation system. But the history said that this person had undergone a very massive Ayurvedic massage in Kerala. And the deep massage led to hemorrhage along the ribs. Similarly, after history, examination is important. Of late, the stethoscope has lost its value. It's only required for the security guard to recognize you as a doctor to enter the hospital. We go with X-rays, we go with the CT scan, we hardly auscultate the heart and the lungs. Clinical picture could be very helpful. What you see on the left side is a person without platelets, and what you see on the right side is a person without factor VIII, who's got a hemarthrosis. These look like purpuric spots, but they were blanching, and hence these were telangiectasia. Purpura, due to platelet deficiency, there is no blanching. This is hand of a 82-year-old man, and on the forearm you can appreciate that there are some bruises. This person had these bruises for last 3 years and only on the forearm. This history is alone enough to diagnose what is called senile purpura because it occurs only on the forearm and only in aged people. This is perifollicular hemorrhage of vitamin C deficiency, scurvy. So these clinical pictures are characteristic. You don't need lab data to diagnose this. Coming back to the platelets, how do you investigate platelet deficiency? So today, we all have automation, access to the cell counters, and these cell counters can tell you that the platelets are low very easily. But the question is, when the platelet count is low by a cell counter, is it really low? There is a condition called Bengal syndrome in India. It's known as Harris syndrome in the Western world. When you have a person whose surname is what is written on the right side, Burman, Basu, Ganguly, Tagore, Bhaduri, Sen, Moitra, Adhikari, etc. And if the platelet count is variably low from different labs, and the person is not a bleeder, it's likely to be the Bengal syndrome, which is characterized by pseudothrombocytopenia due to large platelets which are not counted by cell counter and which are present from birth. Well, let's come to the true thrombocytopenia. Say these three are pictures of a person with platelet count of 12,000, genuine 12,000. Now, this thrombocytopenia could be due to a good disease, a bad disease, and an ugly disease. On the right side, you see a cartoon of a picture, the good, the bad, and the ugly. The good one is low platelet due to ITP. I call it good because these patients do not have much of mortality and not even much of morbidity. Aplastic anemia is the cause of low platelet. I call it bad because some patients could die. And acute leukemia is the cause of low platelet. I call it ugly because many die. So ITP, the good cause of thrombocytopenia, aplastic anemia, the bad, and the acute leukemia, the ugly. When you have thrombocytopenia, never forget hypersplenism. Always do a USG of abdomen. If required, fibroscan of the liver for the hepatic echo texture and the Doppler of the portal system to see whether there is portal hypertension. Clinically, the spleen may not be palpable, but there could be a subtle pancytopenia of which thrombocytopenia can be outstanding. Person may be born with low platelet, the congenital thrombocytopenic purpura. Here is a baby And this is the arm of the baby where there is no forearm at all. This is thrombocytopenia with absent red-eye syndrome. Gray looks wonderful as a trouser and on the head. But the gray platelets, as you see on this slide, are not good. It's a disease. And the gray platelet syndrome is due to lack of alpha granules in the platelets. And these patients are bleeders. When you have a kid with low platelet, before labeling that kid as ITP, and especially before subjecting that kid to a splenectomy as a treatment of ITP, you should always consider 3 differential diagnoses. The inherited platelet deficiency, which we just talked about, primary immunodeficiency disorders, where there can also be immune-mediated problem like ITP, and a systemic autoimmune disease like SLE, where splenectomy will only help platelets and not the disease. This is one paper which tells you that ANA positivity in children, especially after the age of 10 years, and if the ANA is in the titer of more than 1 in 160, represents evolution of SLE sooner or later. Drugs as the cause of thrombocytopenia is common both in office practice and in the hospital practice. As you know, in the hospitals, patients are on 10 plus drugs every day. One of the important cause of thrombocytopenia is heparin. And this is a dangerous condition because it produces thrombosis leading to loss of limbs or even life. Vaccines, and the classical example is the COVID vaccine, just 2 years ago, led to serious thrombotic disorder called thrombotic thrombocytopenia. Chemicals can do the same, and this is extensive tattooing resulting into chemical-induced thrombocytopenia. Now, pregnancy is not a disease, it's a physiological condition. But it's extremely important when the platelets are low during pregnancy. Thrombocytopenia of pregnancy can lead to morbidity and mortality to the mother and the baby. I divide the conditions into 3 groups. On the top, you have relatively benign condition called gestational thrombocytopenia and ITP. In the middle, you have characteristic conditions which are specific to pregnancy, preeclampsia, eclampsia, HELLP syndrome, etc. And at the bottom, you have conditions which occur in pregnancy and outside pregnancy, but they have serious life-threatening complications. And these include the names that are put up over here, HUS, TTP, etc. However, 3 conditions account for majority of thrombocytopenia during pregnancy. As you see over here, in the orange, gestational thrombocytopenia, which occurs in the second half of pregnancy, and these are non-bleeders, they don't need any treatment. Therefore, this diagnosis is basically to reassure the patient. Preeclampsia accounting for 20% and ITP accounting for 3%. Rest all what I talked about account for less than 1%. Normally also during pregnancy, as the pregnancy advances, the platelet count dips, and after delivery, it picks up. This is a slide which shows you what is called microangiopathic hemolytic anemia, where RBCs are getting fragmented and there are no platelets visible. Now, this kind of schistocytes and no platelet is a disaster because it could speak of DIC, hemolytic uremic syndrome, thrombotic thrombocytopenic purpura, and so on. Sometimes you have to search for these schistocytes. Like this slide has just 2 of them. This is a specific entity, the TTP, because platelet transfusion here is contraindicated, and the treatment is to do plasma exchange, which is life savior, and other immunosuppressive drugs. Coming back to the ITP, the commonest cause of thrombocytopenia in office practice of a hematologist. How do you treat this entity? So how do you increase the platelet count? One of the common notion in India is that the papaya leaves juice increases platelet count. And there are some smart businessmen who exploit this thinking and produce tablets from papaya leaves, and FDA in India has approved this. It does nothing to the platelet count, but makes the businessman rich. Treatment of ITP in 2024, rather now I should say 2025, you should first divide the ITP into 3 types. The newly diagnosed, that is first 3 months. The persistent thrombocytopenia, that is from 3 to 12 months. And the chronic thrombocytopenia, which is more than 12 months. The idea of this is that one must not do splenectomy except for patients who have chronic ITP. Not all thrombocytopenia due to ITP need treatment. The one on the left side, platelet count less than 10,000, or the person having active bleeding, treatment is mandatory. The one on the right side with the platelet count more than 30,000, or if there is no bleeding, hardly ever need any treatment. And the one between 10 and 30,000, or only minor bleeding, the clinician has to use his judgment. We have lots of drugs which are used for the treatment of ITP. In an emergency, you have anti-RHD, steroids, and IV gamma globulin. There is a robust evidence for the drugs called eltrombopag and romiplastin. Rituximab is also a very important addition to the treatment of ITP. Most of the patients we are able to treat between steroid, eltrombopag, romiplastin, and rituximab. Many drugs which were used in past, which are general immunosuppressive drugs and are listed here, are sort of obsolete in the treatment of ITP and are used sparingly. And splenectomy is done most sparingly today because you've got such important drugs available to you. The game changer is really eltrombopag and romiplastin, which are thrombopoietin receptor analogs. They increase the production of the platelet rather than block the destruction. These are the only group of drugs which do not cause immunoparalysis or immunosuppression and hence do not cause infection. That's their structure. Both act differently and sometimes we use both together. There's a third one which is not available in India called avatrombopag, which is an extremely safe TPO analog. This TPO receptor analog improve the platelet count slowly, and as you see in this graph, which is in red line, as the time passes, platelet keep moving up and up. Rituximab is a fantastic treatment of ITP because just 4 doses of 100 mg each can lead to remission lasting for 1 year or more. And as I mentioned, splenectomy is used nowadays very rarely. And if it has to be done, it should be the lap splenectomy rather than the formal splenectomy. Those who are not fit, post splenectomy, the spleen can be embolized and that can reduce its function. One important thing is that after splenectomy, the mortality is high. As you see in the red curve on the top and the black at the bottom, double the number of patients of ITP after splenectomy die than those who have not undergone splenectomy. So there are a lot of reasons why splenectomy is avoided today. Then, as I mentioned, there are other immunomodulators like MMF, azathioprine, cyclosporin, dapsone, which we use as a desperate measure. Initially, the first-line treatment of ITP used to be corticosteroids. The game has changed. Today, we often use eltrombopag together with steroid and maybe 1 dose of rituximab, and that is game changer. There are certain orphan drugs for the treatment of ITP. Using treatment of H. pylori has occasionally helped patients of ITP. There is a drug called rilzabrutinib, which is an oral BTK inhibitor and is very powerful treatment for ITP. There is a SIT inhibitor, again an oral tablet by name fostamatinib, can improve platelet count. And lastly, low-level laser therapy to the megakaryocyte can improve the production of platelets from the marrow. There are lots of other drugs on the horizon. I don't have time to discuss, but I'll just mention one over here, bortezomib, and one here, daratumumab. We use this to kill the plasma cell, which ultimately is the source of immunoglobulins. Did you know Nawaz Sharif the ex-Prime Minister of Pakistan, had ITP. And because Eltrombopag was not available in his country, at that time he was jailed, he was allowed to go to UK and he escaped from being killed in Pakistan. And today, of course, he's back to Pakistan as a usual citizen, if not Prime Minister. A word about platelet transfusion. Is platelet transfusion always required when the platelets are very low? The answer is no. Personalized platelet transfusions is a step very close to the clinic. Yes, if you have retinal hemorrhages, it's a forerunner for intracranial hemorrhage. So you must give platelet as a life-saving or limb-saving procedure. But this is a chart to tell you when the platelet transfusion is dangerous, like TTP and HIT, when it is not helpful, like ITP and hypersplenism, and when it is really indicated is bone marrow disease and DIC. Future of thrombocytopenia, there are going to be needle-free platelet meter, which you put on the nail and it can give you the platelet count. And there are going to be wristbands like this, which can give you blood cell counter like data. There's a journal by name Platelet. So if you are a student of Platelet, you should subscribe for this journal. I summarize by this presentation as the learning points, 10 things that you must not do. Not to skip history and examination, minimum of telemedicine when it comes to platelets. Do not trust electronic platelet count. Have a look at the peripheral smear and sometimes the manual platelet count. Not to investigate mild thrombocytopenia, especially platelet count above 100,000. Always try to differentiate between good, bad, and the ugly causes of thrombocytopenia. Never forget congenital thrombocytopenia, even in an adult and elderly. In pregnancy, commonest cause is gestational thrombocytopenia, which is innocuous. Don't do splenectomy for ITP unless you have exhausted all the resources. Do not give platelet transfusion unless you know the etiology of thrombocytopenia or it is life savior. And liberally use Eltrombopag and Romiplastim, which are game changer for a lot of conditions causing thrombocytopenia, commonest being ITP. I'm passionate about platelets. I'm passionate about ITP. I'm passionate about hematology. Well, thank you so much for giving this opportunity to speak to you.
Can you hear, sir? Hello?
I can hear you.
Light, please. Light.
Hello. Yeah, after hearing this wonderful lecture, as usual, Professor M.B. Agrawal is known for his excellent talks and his simple but very thorough explanations about his subject must have satisfied you all. Professor Agrawal has been a stalwart in the hematology and is very well known for his lucid lectures. I'm very sure all of you must have experienced the same many times earlier also. I thank Dr. M.B. Agrawal profusely from on behalf of the organizers. And if there are any questions, I think I should. Dr. Sangmesh?
I think so, sir has exited.
I should,
Just
thank you.
Just a minute.
No, I'm there. I'm there.
Yeah, yeah.
Yes.
Okay, sir. Okay. Yeah.
Thank you so much, sir.
Any questions from audience?
Any questions from the audience?
Please, volunteers, please pass on the mics. Sir, actually, there is some dim light over here because we are conducting PVR cinemas.
I can see Mr. Chavanda very well.
Good afternoon, sir.
Good afternoon.
Sir, I have one question. When we do the retic count, we correct it for hematocrit. Does IPF need such a correction?
No, not really. There is no correction for IPF.
Okay.
There is
No
a question
questions,
in the chat box. It reads, during pregnancy at full term, at what platelet count can we do the C-section? C-section requires a platelet count of 50,000 plus, but if we are going to give epidural, then 75,000 plus. That's the only question I have here on the chat box.
Thank you very much, Doctor.
Hello.
Professor.
Hello.
Thank you.
Sir.
Thank you.
Thank you.
Well,
Yeah.
good afternoon, sir. I'm a nephrologist, Dr. Akshay Kulkarni. I wanted to know, we usually get a call for pregnancy-related AKI in the third trimester with thrombocytopenias. And as you have elaborately explained regarding the plasma exchange, my question is how aggressive plasma exchange you recommend? What volumes of plasma exchange you recommend, whether an alternative day or a daily basis? And what criteria you would like to monitor as a hematologist? Thank you, sir.
Thank you. So the really worst of the condition, which is most helped by plasma exchange, is the TTP, thrombotic thrombocytopenic purpura. The diagnosis is based on ADAMTS level less than 10%, and whether it is acquired or genetic is based on the presence of antibody against ADAMTS 30. Now, both these tests are either not routinely available or they take days together or sometimes weeks for the information to come. So you have to make a clinico-pathological diagnosis in the absence of it, presence of cystocytes, hemolytic anemia, characterized by bilirubin, LDH, haptoglobin, all those things, renal shutdown. If there are other clinical stigmata of ischemia affecting brain, GI tract, cardiac, makes us think that this could be TTP. And if you think of TTP, then you need plasma exchange on the spot without diagnosis. Even if you are wrong, it's okay. In this situation, you do the plasma exchange daily for minimum of 5, and you go by platelet count, which must go above 100,000 stable for more than 2 days, and LDH, which should be less than 2 times the normal, and again for more than 2 days. You may require 5, 7 or more, but minimum 5. Once you stop doing plasma exchange, of course, simultaneously you're giving corticosteroid and rituximab. Once you stop doing plasma exchange, again you see the platelet count and the LDH. If the problem is recurring, you continue the plasma exchange. Sometimes you have continued it for 2 weeks and even more. So this is the worst of the condition where you do plasma exchange. Many times you do it and then realize that this is not TTP. Then you abort the procedure after 1, 2, 3.
Thank you, sir.
Thank you so much, sir, for that insightful presentation. Indeed, platelets are the band-aids of the bloodstream. You told us the importance of platelets in very elaborative way, as they were initially called dust in the blood, but they are the unsung heroes of blood. We are truly grateful for your valuable guidance. You stand tall amidst the gala of hematologists. Thank you so much, sir, for connecting with us. Thank you.
Volume, please.
Felicitate the chairperson.
स्क्रीन करायचं होतं. स्क्रीन बंद करू काही लॉग आउट कसं करू इथं लिव्ह हां व्हॉट्सअप करतो.
त्यांचं झालं का?
झालं.
म्यूट करू
म्यूट करू.
Now it's time for the official inauguration ceremony of this Hematology Conference 2025 Latur chapter, which is organized by IMA Latur in association with Vilasrao Deshmukh Government Medical College, Latur, Department of Pathology.
स्क्रीन कसं करायचं शटडाऊन करायचं मागची स्क्रीन तात्पुरता कसं बंद करू तात्पुरता एक दोन सेटिंग करायचं मला
We will start with our inauguration ceremony. I request all the delegates to kindly stay in the auditorium for the inauguration function, which will be followed by lunch. All the delegates kindly be seated as we have all the chief guests here for this inauguration program.
लाईट चालू करू द्या
Good afternoon, ladies and gentlemen. Here we are performing the inauguration ceremony of this Hematology Conference organized by the It's my pleasure and honor to invite all the dignitaries present here for this inauguration ceremony. And I request the organizing president, Dr. Umesh Kanade, and the organizing secretary, Dr. Sangesh Chanda, to escort our chief guest and guest of honor to the dais. To begin with, my pleasure. It's my pleasure to invite the president of this inauguration ceremony, Dr. Anita Borges, madam, to the dais. It's my request to Umesh Kanade and Dr. Sangesh Chanda to escort all the guests to the dais. The chief guest of this inauguration function, Dr. Kailash Sharma, the guest of honor, Dr. Sumit Gujral, Dr. Savi Nalinkari, Dr. Girish Mahendarkar, Dr. Nawab Jamadar,
It's a projection there.
the college, Dr. Uday Molte, Dr. Sandeep Kauthale, Dr. Ajay Over, and Dr. Sanjay Modi. I request all the dignitaries to come over the dais, please. Dr. Sandeep, Dr. Uday, Dr. Girish, please come on the dais. Dr. Ajay Oil, Dr. Sanjay More, Dr. Savi Melinkeri, Dr. Sumit Gujral, we have a galaxy of dignitaries on the dais for the inauguration ceremony. Dr. Kailash Sharma, sir. Ladies and gentlemen, we have all the dignitaries on the dais and request all the guests and dignitaries on the dais to proceed with this symbolic inauguration ceremony. Pay our respects. Dhanvantri, Dr. Pancha, Vargatni, Dr. Vasan Manoj. I request all the dignitaries to extend our respects, gratitude. Morning will be led by Dr. Shaw, Dr. Jimmy Morgagni, Dr. Vasant Khanolkar, and Hanuman God of Swedish. Rudolf Virchow is considered the father of modern pathology. Virchow made significant contributions to the understanding of cellular pathology, the role of disease at the cellular level. His phrase, omnis celluli is cellular. All cells come from cells is a foundational principle in biology. Dr. B.R. Khanolkar, the father of Indian pathology, monumental work in applied biology, experimental biology, epidemiology, the Dharma God of prosperity, health, and healing. Dr. Morgagni, father of medico-pathological correlation. Thank you all for doing the honor. It's our duty to welcome guests for the inaugural ceremony. I call upon the organizing president of this conference, Dr. Umesh Kannade, to welcome the president of this inaugural ceremony, Dr. Anita Borges back. Dr. Umesh, welcoming the iconic, the legendary Dr. Anita Borges, Madam. And I call upon Dr. Sanjay Chowda to welcome Dr. Kailash Sharma, the chief guest of this inaugural ceremony, son of the soil, Health and Latur, ex-director of Tata Memorial Cancer Hospital, who has been kind enough to grace the occasion as the chief guest. Dr. Sunil Kudral will be welcomed by Dr. Vantai. Dr. Sunil Kudral will be placed by Dr. Narendra Bhatt. Is he here, Dr. Narendra? Okay, Dr. Ajuta, please stand in line for Dr. Narendra Bhatt to do the honors and please welcome Dr. Salim Medinte. I request Dr. Chetan Sarda to welcome our own Dr. Dinesh Mendarkar, President of CS, CP, CPS, member, renowned physician, Dr. Chetan, welcoming Dr. Dinesh Mendarkar. Dr. Kapil Dugdale will welcome the Dean of MIMSR College, Dr. Nawab Jamata. The Dean of College, the host of this conference, will be welcomed by Dr. Sati Mingale.
I earnestly request Dr. Manjana ma'am to have a seat on stage. Please, ma'am. You being here. Our pleasure, ma'am.
Moreover, I request Dr. Ajay to welcome Dr. Manchanda, Madam. Thank you, Madam. And now, Dr. Shubhangi Kolekar will welcome Dr. Sandeep Kauthare, guest of honor. Incidentally, Dr. Sandeep Kauthare has been elected as the President of Indian Radiology Association of India with a huge margin. We are proud of you, Dr. Sandeep, for being on the national stage. And for that, we would like to express our happiness and request Dr. Kailash Sharma to felicitate on behalf of the organizers and Latur city. Another son of the soil, Dr. Sandeep Kauthare, President of IRA, Delhi. Latur has produced many faces on national stage. He is the new entrant, the dynamic, little dynamo. Thank you, Sandeep. Dr. Rupesh Kundawar will welcome our MMC observer for this event, Dr. Ajay Ohar. And Dr. Sushmita, please welcome Dr. Sanjay More, the Maharashtra Ministry of Health Science Observer, Dr. Sanjay More. Please, it's pertinent to welcome the organizing president of this event, Dr. Confernce, and I request Dr. Acharya to welcome you. The organizing president who has taken a lot of efforts to realize this conference. Our colleague, Dr. Umesh, being pathology. Same is true with the enthusiastic organizing secretary, Dr. Sangeet Chawda. I request Dr. Keshav Vijay to welcome Dr. Sangeet Chawda.
Thank you so much to all our guests of honor. A true welcome is never complete without warm words and warmer gestures. I request our organizing president, Dr. Umesh Kanade sir, professor and head of department of pathology, VDGMC Latur, and president IMA Latur, to accord a formal welcome to all the dignitaries and introduction to our hematology conference.
Very good afternoon to all. Honorable stage, the president of today's function, Dr. Anita Borges, the chief guest, Dr. Kailash Sharma, Dean VDGMC Latur, Dr. Uday Mohite sir, Dean MIMSR Medical College, Dr. NP Zamada sir, ex-president CPS, Dr. Girish Mandarkar sir, the guest of honor, Dr. Samir Milenkeri, Dr. Sumit Gujral, Dr. Sandeep Kauthare, who is recently elected as President IRA, the MMC Observer, Dr. Ajay Ohar sir, MUHS Observer, Dr. Sanjay More sir. I would like to announce once again this oncopathology workshop and the Hematology Conference has got 6 credit point accredited by the MMC. So this conference, Oncopathology workshop, and this Hematology Conference is basically organized by IMA Latur, VDGMC Latur, MIMSR Medical College Latur, Latur Practicing Pathologist and Microbiologist Association, Association of Physicians, Surgical Society Association, Indian Association of Pediatrics, and Latur Obstetric and Gynecological Society. Ladies and gentlemen, once again I welcome you all. Today we mark a unique and groundbreaking event as we gather here today at the PVR Cinema. This is the first of its kind continuing medical education program. This exceptional venue sets the stage for a memorable experience, highlighting the critical advancements in the oncopathology and hematology. I would like to begin by expressing the immense gratitude to Dr. Anita Borges. Her dedication to the unfolding the intricacies of the oncopathology has been nothing short of the inspiring. Her words today reinforce the important contributions of this field to the oncology. We are also deeply thankful to our esteemed guides, Dr. Sumit Gujral, Dr. Asauri Patil, Dr. Ayush Sahai, Mr. Shashikant Mahadik, whose insights have been very instrumental in crafting an academically enriching event we have conducted yesterday as oncopathology workshop. The learning together under microscope was the theme for the yesterday's oncopathology workshop. A heartfelt thank you goes out to all the institutions involved in the oncopathology workshop and the conference. Your support extends opportunities for the enthusiasm from the students to the consultants and practicing doctors to engage and learn continually. Now, as we stand on the brink of expanding our horizons in the hematology practice and diagnostics, we must honor the journey from the fundamental complete blood count test to highly sophisticated diagnostic tests. These advancements play a pivotal role in shaping the comprehensive healthcare solutions. Let's all acknowledge the interdisciplinary nature of our field, where clinical, paraclinical, all the branches, those who are involved and participated actively in this oncopathology workshop and the conference, today's hematology conference. I would like to mention here, everybody has a question, how you have got all those stalwarts on one day? I don't have answer, but I found something else which I would like to tell you. The dialogue of the Shah Rukh Khan's movie, Om Shanti Om. अगर किसी चीज को दिल से चाहो, अगर किसी चीज को दिल से चाहो, तो पूरी कायनात उसे तुमसे मिलाने की कोशिश में लग जाती है. That's what today I found. Everybody has got. I am very much delighted to have all of you here in the Latur, because I didn't thought that all of those stalwarts will be there in Latur on one day. I once again thank you very much for all the team oncopathology, team Tata Memorial Hospital, team DMH, also the Ruby Hall, and everybody, Dr. Vijay Shure, who has come across from the Gujarat, Ahmedabad, Dr. Sandeep Nemani, everybody out there, all delegates, my PG students, all the postgraduate students, those who have come from the outside Maharashtra, from Karnataka and Telangana. I thank you very much. Enjoy this today's session. Thank you.
Thank you, Shah Rukh Khan of Latur Pathology. You yourself are a stalwart, and so you have made the things realized. There is nothing surprising. And the theme of this conference, Learning Together, reflects the commitment to addressing the current challenges, breakthroughs in oncopathology and hematology, ultimately aiming to improve patient outcomes and transform our care delivery. Thank you, Umesh, for being such a wonderful host, such a hospitable person. and bringing this conference to Latur.
Now I request Dr. Uday Mohite sir, Dean Vilasrao Deshmukh Government Medical College Latur, who is indeed the primary host of this conference, to guide us.
Good afternoon. Today's chief guests, respected Dr. Kailash Sharma, Dr. Anita Borges, Dr. Girish Maindarkar, Dr. Samir Milinkeri, Dr. Sumit Gujral, Dr. N.P. Jamadar, Dr. Umesh Kanade, Dr. Sangmesh Chonda, Dr. Sandeep Kauthare, Dr. Ajay Hoar, Dr. Sanjay More, distinguished speakers, esteemed colleagues, and all delegates. On behalf of Vilasrao Deshmukh Government Medical College, Latur, it is both a privilege and a pleasure to welcome you all to the Oncopathology Workshop and Hematology Conference 2025, a gathering dedicated to the clinicians, surgeons, pathologists, and amongst all the field of medicine. Pathology lies at the very heart of understanding disease, driving innovations in diagnosis, treatment, and patient care. As an institute, Vilasrao Deshmukh Government Medical College, Latur, we are committed for quality undergraduate and postgraduate education, research, and patient care. As part of pursuing these goals, we encourage organizing various workshops, conferences, and CMEs. At our institute, we have 150 MBBS seats and 70 PG seats per year, with pathology department having 5 PG seats per year, that is 15 budding pathologists at any point of time. We are honored to host such a conference first time in Latur, and that too in an ambient environment of PVR cinemas. I would like to congratulate Dr. Umesh Kanade and the Department of Pathology, IMA Latur, MIMSR Latur, and all organizing team for organizing such conference at Latur. The beginning of conference was marked by successful conduction of anemia and cancer awareness rally to spread word of awareness in community. I hope this conference serve as an invaluable platform for sharing the latest breakthroughs, discussing emerging trends, and collaboration on solutions that can transform the future of pathology. I would like to appreciate efforts put up by Dr. Umesh Kanade, Dr. Sangmesh Chonda, the organizing committee, the dedicated volunteers, our speakers, and all those who have worked so hard to make this event successful. I would like to make a special mention about Venue PVR Cinema, that this conference has marked potential use of its infrastructure for an innovative cause. At last, I wish for a great success for the conference and a grand academic feast for delegates. Thank you. Thank you very much.
Thank you, sir. On behalf of Department of Pathology and whole organizing committee, I thank you for guiding us throughout this journey and supporting us in all possible ways in organizing this oncopathology workshop and hematology conference in PVR Latur. Now I request our guest of honor, Dr. Girish Maindarkar sir, to guide us.
Good morning, all. For the inauguration of this Hematology Conference 2025, organized by chapter of Indian Medical Association Latur branch in strong support with Dr. Vilas Rauji Deshmukh, Government Medical College Latur, all the pathologists of pathologist and microbiologist of Latur, all the friends from Latur, MIMSR Medical College Latur, I would like to welcome on this occasion Dr. Anita Borges ma'am, whom I know from my residency days, because my teacher, Dr. Kumud Mehta ma'am, Dr. N.C. Joshi, Dr. Saroj Parekh ma'am, they used to send us to take the opinion. We have been told at that time that she looks at the slide like this and tells the diagnosis, and that's true. Even we used to see in second MBS the slide, but to see the marking on the corner of those slides. And then Mama used to tell us, दो लाइन है ना, दो लाइन वो उसका slide है. So the person who has always been supportive to the Latur team, who has taken the charge of Dean, Government Medical College Latur, Dr. Uday Mohite sir, who is the best, one of the best academicians and a supportive person, Dr. Nawab Jamadar sir. One of the important person from Latur, everybody knows, and the stalwarts on the dais also knows, Dr. Kailash Sharma sir. I think one more introduction of Kailash Sharma sir, you might have forgotten, so let me introduce. He was the BOG, Board of Governors of MCI. He was Board of Governors of NMC. And for our oncology unit of Vivekananda Hospital, he was the instrumental in getting all the grants and everything from Tata. So he has helped Latur, being the son of soil of Latur. He was always been helpful for the patients and for all the doctors from Latur area. Welcome, sir. I welcome Dr. Samir Malenkiri, sir, Dr. Sumit Gujral, and last but not least, the person who is instrumental in getting everyone amongst us to be present for this academic feast, the Shah Rukh Khan of Latur, Dr. Umesh Kanade, and the backbone of IMA Latur, Dr. Sangmesh Saunda, their team, our own Dr. Sandeep Kauthale, who is now the national president, elected national president of IRI. So let me start first thanking the organizing team, Dr. Umesh Kanade, Dr. Sangmesh Saunda, that such a great event they have organized in Latur. And to be more frank, I have not seen such a big gathering amongst the pathologists and microbiologists with such an interest and such a stalwarts coming to a place like Latur for the conference. So I wish all the best to this conference, and I wholeheartedly thank all of you for coming from Latur, from around Latur, from different parts of Maharashtra, Gujarat, gracing this occasion and making this conference a big success. Thank you very much once again to you all, and Dr. Umesh Kanade, who has organized this conference, Dr. Sangmesh Chaunda. Thank you very much.
Thank you so much, sir, for your valuable thoughts. Now I request our esteemed guest, renowned hematopathologist, Dr. Samir Melinkari, sir, to share your thoughts with us.
This was not on the agenda, so I'm not prepared. No, I would just like to just say that this is the first time I've ever come to Latur, and it's great to see so many people who come for this conference. I think the conference is very well arranged, especially the workshops. And Dr. Gujral was telling me about how he and Dr. Borges have been coming and educating pathologists all around the country actually. So that's something really very creditable. Nothing. I would just like to wish everybody a great conference, and thank you for all the efforts that you've all taken. Thank you.
Thank you so much, sir. Now I take the privilege to request our honorable chief guest, Dr. Kailash Sharma, sir, to address the young delegates and motivate them by his words of wisdom.
Well-known dignitaries on the dais. The final word in oncopathology, my friend and my philosopher, Dr. Borges, Dr. Gujral, all the organizers of this event from Latur, like Medical College, Dean, other medical college, then IMA, pathologist, hematologist, and all my colleagues. And all the fellow and all the students and the teachers who are all over from, say, Marathwada or from Pune or Mumbai, they have gathered here and they enjoyed the very fantastically organized oncopathology workshop by Dr. Borges and the oncopathologist of Latur. I must thank the organizers. I'm not a chief guest. I'm from Latur and I'm very old friend of all these organizers. That's why they have called me with love. And I still love my place, my native place, and they call me as a son of soil. There is nothing like whatever I was at school and then college at Aurangabad, and then just by luck only I went to Tata Hospital. I'm not an oncopathologist. I'm not oncologist. I'm a supporting oncologist, anesthesiologist. And then I had a very good experience in doing the programs in oncopathology, then hematopathology, like training courses, fellowships. And when I was in Tata Hospital, I used to say that oncopathology department of Tata Hospital with all old people, how they learned. They learned by practice, by their dedication, their involvement, and the enormous study in the subject they learned. Nowadays, there are qualifications also available, training also available. So from Tata Hospital as a director academic, and as it was mentioned that when I was board of governors at Medical Council of India, that time I realized that the three core subjects of oncology like surgical, medical oncology and radiation, yes, they are the pillars, but without oncopathology, without hematopathology, I don't think anybody can work. And they give the final word, final diagnosis, the further stratification of the risk, stratification of the disease, grading, and ultimately with molecular diagnostic targets and all the markers, they give further guidelines to the treatment, like the modern treatment of, say, immunotherapy and targeted things like lung or any other thing. I'm not an oncologist, but I see the reports and I study, then I find that there is a specific way of reporting also, which Dr. Borges will speak. It's not my subject, but I have learned by only seeing the things. And I thought that there is a need to train and may become the qualified oncopathologist. So at 2014-15, when I was a board of governor, I started DM in oncopathology. And this is now available at 9 centers all over India. And some 30 students every year, they pass out of DM in oncopathology, 3 years rigorous training in cytopathology, histopathology, hematopathology, and molecular pathology. So all these branches combined, when it is in one roof, then only you can start this course. But yes, Dr. Borges and Dr. Gujral has taken a fantastic and novel step of going to each tier 2 and tier 3 cities and this thing. So it's a fantastic way of, and I must say that it's a traveling school of oncopathology and traveling school of hematopathology. Very important branch. In Marathi, if somebody may not understand, what was when I was MBBS student, and I think there were few pathologists, and nobody used to take MD in pathology. Very, very neglected subject. And people used to have a laboratory where they used to some diagnosis, and outside there was one board, रक्त लघवी आणि थुंकी ह्याची तपासणी करणारे डॉक्टर म्हणजे काय पॅथॉलॉजिस्ट आहेत पण टुडे in oncology, when we realize they are the real backbone and they only can guide the best treating oncologists wherever they are. And then so many things are needed to train oncopathology at every medical college. When we say that there are training programs going on at Tata Hospital for last so many years, and we request that there should be a sponsored training program that government of Maharashtra or any government, the director of medical education should sponsor their assistant professors who are very eager to learn the subject. They should come to big centers like Tata Memorial Hospital and the innovative centers by Dr. Borges, that is Center for Oncopathology, created by Tata Trusts. There they do and they give the second opinion. All over India, slides and blocks and specimens come to them and then they give the final word, where everything is required like histopathology, grading, immunohistochemistry, and molecular targets and the markers. So up till now in Tata Hospital, if I look at all the previous years when she was also there, Dr. Borges, they used to train only few students because there were no training programs. Everybody used to come to Tata Hospital to get training 6 months, 1 year. And then there was a structured training program under Homi Bhabha National Institute, University, that fellowship of 2 years. Up till now, so many fellows have been trained by Tata Hospital. All over India, they are working. Then there are so many trainees also come to Tata Hospital, duration of 6 months to 1 year. And now Dr. Borges will be starting a training program for any pathologist from a recognized institute, from an institute, from a practicing word. Either it will be a 6-month training or 1 year training, and fellowship also continues at Tata Trust. When I started working at Tata Trust way back in 2018-19, we realized that we are going to open 19 cancer hospitals all over India. Where are the oncopathologists? So that time I started oncopathology training, and we have trained under Dr. Borges' mentorship 6 trainees for Assam, and there are 4-5 trainees who are working right now at Tirupati, Ranchi, and will be working at Chandrapur. So this is very successfully managed by Center of Oncopathology by Dr. Anita Borges and Tata Memorial Hospital also, because Tata Memorial Hospital has a large volume. So they also learn their grossing and slide making. Very important aspect of this conference, like hematopathology and oncopathology combined together, which is such a novel measure that IMA and the practicing oncopath, I think way back in 10-15 years back, Dr. Ayachit and Dr. Kulkarni, who joined with me at Civil Hospital Latur way back in 1983, they were the only 2 oncopathologists giving best reports, and I think they were trained, maybe, I don't remember, at Tata Memorial Hospital in past or no idea. But nowadays, a lot of people are coming. But I have seen over a period of last 15 years, dean or director, if anybody is here, they may mind that there is a clear apathy at the government level to send the eager people for training, maybe at least 6 months or 1 year. They are on deputation. They should give deputation because salary should continue, and there should be some bond that they will come back to the hospital and they will establish an oncopathology department at a running medical college. Then when we started 20 state cancer institutes and 19 TCCs like tertiary care cancer centers all over India, the government of India and Maharashtra government and any other government, state government gave the budget, but there were no budget for oncopathology. How many medical colleges have, say, cryostat, frozen section, ISC facilities? So every department should be strengthened with all these facilities. Then only people will have, will be eager to learn, absorb the technique and the knowledge, start attending the conferences, and they will successfully become oncopathologists. The country requires good oncopathologists at each, say, district or a town level, where there are surgeons practicing, there are medical oncologists practicing, and they need support of such qualified or maybe trained people so that they can really guide them. So I must thank the organizing committee for inviting me. It was my pleasure to come to my native place. And Sangamesh, my friend's son, he asked me 2 months back, and then I said, yes, Latur, I am always ready. And don't worry, I will come in any capacity, whatever you want. And he told me, you are chief guest. No, I'm not an oncopathologist. I'm just a supporting oncologist from Tata Hospital. But with my affection, with my love, and all with my colleagues, and plus my colleagues like Borges and Gujral, today I'm here feeling very happy and proud, and all the best for this conference. And I think they have really enjoyed the workshop which was there at DG, and today also so many lectures. I could only attend Dr. M.B. Agrawal's lecture, and this really gives some insights into it. And Dr. Borges and Dr. Gujral, they are the encyclopedia of oncopathology and hematopathology in this country. You name the person and they will remember in all over India that yes, they have met her, they have seen her, they have seen her teaching, they might have referred some slides, they might have referred some relative slides, they might have come back to Mumbai and met her and got her final word. So final word in pathology, which gives the direction to the treating doctor that how it should be treated, when it is to be treated, and how the prognostic markers, they give your guidance in the prognosis and the stratification of the disease. So they are really stalwarts. So thank you very much. And on my behalf, as a son of soil or whatever, I'm from Latur, I must thank all the people on dais that they have organized such a big conference, and all the branches of the all the branches of IMA and the different branches of medicine which are practicing in Latur. Latur is a huge IMA branch, very strong IMA. I appeal them that every year they must have some small micro branch conference, specialty conference organized by them at Latur, so that the stalwarts all over India in that subject will come. They will see Latur. Latur has got their own definite pattern of education and the pattern of medical service also. Thank you very much. Namaskar.
Thank you, sir, for the appreciative words. Your love for Latur was palpated. Sir, anything and everything is possible when you have the right people there to support, and you are one of them for us. And you were appreciative of Dr. Ruzuta Aichit, madam. Let me tell you in one sentence, Dr. Ruzuta Aichit, madam, is Dr. Anita Borges of Latur. Thank you, Sharma sir. And now I request Dr. Sumit Gujral to express.
Thank you, Umesh, everybody, for having us in Latur. We had a very good time. I won't take time. I think we had a great time, and it means a lot coming to Latur and with this meeting, because what me and Anita and other friends from Tata Hospital and elsewhere have been trying to do, to go to tier 2, tier 3 cities. We go not to educate, we go to learn ourselves. It's not educating anybody. We all learning together, and we get to see places and we get to meet wonderful people as you all. So thank you once again, all of you, and Umesh, for giving us this opportunity to come to Latur. Thank you.
Thank you so much, sir, for your kind words. Now I request the president of our inauguration function, Dr. Anita Borges, ma'am, to kindly guide us. Thank you, ma'am.
Just breaking the protocol. I just wanted to thank all the pathologists, microbiologists, and the histopathologists on behalf of all the clinicians, because of whom we became the renowned and famous over a period of time as a clinician. So this word of appreciation I wanted to tell before the president's speech. And I want to thank also MMC Observer and MUHS Observer. Thank you. Sorry for breaking the protocol.
What can I say? Thank you very much, Umesh, for having invited us to this place. I feel a little illegitimate, actually, standing over here because all of you have come for a hematocon conference. And I don't do any liquid hematology at all. But it was the goodness of Umesh to have agreed to Dr. Gujral's request when Umesh rang Dr. Gujral and asked him to speak at Hematocon. Dr. Gujral said that he would come if he could drag Dr. Borges and Dr. Asavari, and yes, and Dr. Ayushi, and of course, we have somebody who has really kept hematology on its toes, and if he could bring them with him to Latur. And it was really your kindness and your goodness to say yes. That's how we are here. Otherwise, you would have had a very successful hematocon. But the 2 days prior to that, I think, has been a revelation to us. And as Sumit said, really, we have been enveloped with love and attention. I've been still trying to count the number of bouquets I have received. And I'm not really sure, but it's filled my hotel room with the scent of, roses and all sorts of other things. Gifts, bouquets, and really genuine love. So thank you very much for that. But I just want to say a little bit about at least my life as a surgical pathologist and what it is I have tried to achieve in that time. Yes, try to achieve good professionalism, and that happens. You've just heard, two people tell you how long ago it was that they, sort of met me. It made me feel a little old, but I have spent a long life in this field. And yes, if you spend a long life in the field, you do achieve a certain amount of professional expertise. Anybody who's got as much gray hair as I and has worked at Tata Hospital, if you haven't got any expertise, then there's something wrong with you. But what I have tried to do all my life, and that's why I'm so grateful to Umesh, is to convey what it is that I have learned by experience, to convey it to other people. And yes, as Kailash said, we have had students, many students at Tata Memorial Hospital, but they have come to Tata Memorial Hospital. They still come as fellows to the center that I'm working at, that is the Center for Oncopathology that the Tata Cancer Care Foundation has initiated. But I feel that these are just a few people that you can touch. And therefore, if you can take your knowledge and your expertise out of the centers where you work, I think, at least as far as I'm concerned, you are doing what you feel very passionately about. And I feel very passionately about educating others. And this is an initiative that many people feel that they are doing by holding CMEs, continuing medical education. And I believe that continuing medical education, I was here when Dr. Manchanda gave her talk, and then Dr. Agarwal gave his talk. Yes, it does really open up minds and gives people information. But I feel there is something more to this kind of continuing medical education, because this kind of continuing medical education that you've just seen and you're going to hear people for the rest of the day is sometimes a one-way kind of traffic. People talk, others listen, and sometimes take home messages, very valuable messages, but also some of them ask questions. But if, just if, you could have a kind of medical education in which people present their problems, they present their cases, and absolutely unknown to the so-called experts, okay? Because it's very easy. I can show you a slide seminar, I can teach. These are cases that I have already solved. So I know everything about it. And then everybody says, ah, wonderful. Yeah. But what if we had to go and actually learn from cases that you present to us? Yeah, or people in the audience, a collective lot of, I'm talking now about pathologists. It could happen for clinicians, it could happen for anybody. So it's like, it's not a master class. It is if it is a master class, it's the masters who are learning, frankly. And we can learn together about the problems that are present at the periphery and learn how to solve them, okay? Because I know a lot of people who come to continuing medical education programs go away, many of them who come to my institute, many of them who go to Tata Hospital and spend some time there, they go away saying to themselves, I can't do this at my institute. And they are paralyzed by the thought that I don't have this, I don't have that, I don't have this marker, I don't have that marker. So how am I going to make a diagnosis? And I think that doesn't enable people, it actually disables them. And therefore, if we can take, as somebody called it, a traveling school to the, to tier 2 and tier 3 cities, where this kind of feeling that we can't achieve what somebody else has achieved somewhere else, or only a few people can achieve it, if we can remove this fear by coming together, yeah, together, everybody, not just us. And as I was saying, there is, we take a technologist along, and Shashikant is the technologist who spent some time in the hematology department at your institute. If we can work together to uplift intellectual capacity in oncopathology, but I'm sure it can be done elsewhere, and also do something that we did on the first day here, and thanks to the dean who came and sort of met us when we were doing this, we did a little tumor board. And if we could do this kind of exercise and then evaluate it to see whether it's really working, I feel that at this fag end of my life, I will have achieved something. So I really, really am very thankful to you, Umesh. I'm very thankful to the Dean of the Vilasrao Deshmukh GMC for having given us this opportunity. It's you who have given us the opportunity, right? I think that the hematology, this hematocon, gave you the opportunity to invite us over here. And I'm very glad that we came here. Latur is, I've never been to Latur before, but I know people from Latur. The chief one of them, son of the soil, is sitting right here. Kailash, I've known him for many, many years. Kailash, you remember? When I was in the frozen section room, your room as an anesthetist used to be on the opposite side. And then his room was overlooking the only piece of green garden that Tata Hospital had. And he used to call it his garden apartment. And we used to have coffee together. Yes, he used to make good coffee, that much I can tell you. And we used to have coffee together in his green garden apartment. So it's my contact, very tenuous contact with Latur, but I'm so glad that I came. I think I can speak on behalf of Ayushi and Asavari and Sumit and Shashikant, and of course on my behalf, that we were made very welcome. And I think, or I hope, maybe this part I should hope, that our visit over here will be one of the highlights of this hematocon, because the main highlight, ladies and gentlemen, is what? That you're sitting in a PVR. Yeah. And you're seeing everything on this huge screen. And I have to thank, I suppose, Sangmesh and the whole team, you know, that they used to sit here and test whatever had to be done, because now you're just projecting. But yesterday when we were here, it was, there was an actual microscope. And we learned under the microscope. There were slides that were projected. We were not doing seminars on a PPT. So the slides were actual glass slides were being projected, and people were being asking us, and we were asking them, what do you think that cell is, or this, or why are you saying what is what? No, and they would ask us, why do you think that you are saying this about something? So that I thought was a very good interaction in the PVR. And that's the first time it has happened in a cinema like PVR. And I think not only is it, as somebody said, a kind of, the PVR guys are looking at it, as a commercial venture. Yes, it's a business model now. I'm sure that it will be a business model. But more than that, I think you have shown that you can do this. Good audio visual, good big screen, a lot of seats, nice, way of sitting so that people are not craning their necks. And I think that you're a trendsetter in many ways, Umesh. So thank you very much indeed.
The main pillars behind this conference. Yeah, not embarrassing.
Girish, yes, you're an orthopedic surgeon. Yeah, but you have another career if you ever want to give up orthopedics. Yes, yes, and that's being a fantastic MC. All right, Anchor, why aren't you in TV? Huh? Thank you so much, Girish. You've really done a fantastic job. Yes, thank you.
For pathologists and the budding students and their friends, only one thing I used to tell Dr. Borges, that when they have pentahead microscope and when she puts slide and everybody starts looking in the eyepiece, I used to tell them, आंखों आंखों में प्यार हो जाएगा.
Madam, was not for nothing I called Dr. Mukesh as Shah Rukh Khan of Latur. It was him who got us to of this conference. Thank you very much again.
With your permission, one announcement is there. Today we have a gala dinner banquet at nearby this PVR after 7 p.m. onwards at Bharat Fine Dine. So everybody please join for the gala dinner. So don't move or don't go outside Latur. Thank you. Thank you very much. You are there.
I take objection to that. Okay, I can tell you the real quote is that surgeons are those who know nothing, do a lot. And the physicians are those who know a lot but do little. The pathologists know everything, but it's often too late.
So after a successful event of infectious disease conference, which was held in month of September, which was first ever dedicated conference on infectious disease, Dr. Umesh and me bonded together at that point of time. And today we came up with Hematocon. On the behalf of organizing committee, it's my privilege to deliver a vote of thanks on closing the inauguration ceremony. First ever foremost, I would like to thank Chief Guest Dr. Kailash Sharma sir for gracing this event. Our deep appreciation goes to Dr. Anita ma'am, Dr. Gujral sir, Asawri Patil ma'am, Ayushi Sahay for invaluable guidance. We are grateful for the distinguished speakers from hematology, Dr. Manchanda madam, Dr. Shashi Apte sir, Dr. Milind Kiri sir, Dr. Nemani sir, Dr. Anushri madam, Dr. Vijay Shirure, Dr. Ramnan sir, he is, I think so, in the hall. Oh, Dr. Nilkan Poddar, Dr. Santosh Khoba, and all the participation is appreciated. Our sincere thanks for the co-hosts, API, Surgical Society, practicing pathologist, and MIT, and foremost and MUHS who has granted grants for this conference. I would like to thank MUHS Observer, Dr. More sir, Dr. Ajay Owa. I would like to thank MIMSR College and VDGMC Deans for active participation by their students and support. I would like to thank PVR and their organizing team for exceptional venue and catering this event perfectly. We express gratitude for all faculties who has traveled a long way to conduct this event. Finally, a big thank you for audiovisual team, catering services for smooth running of this conference. And finally, I thank all the delegates coming from Gulbarga, Hyderabad, maybe I don't know most of them, but I thank one of you. We hope that see you at future events. Thank you very much, and we'll break for lunch.
One more announcement.
So one more thing, I would like to thank Dr. Girish Kore sir for wonderful anchoring.
Well appreciated, everybody. You have appreciated everybody, and everybody appreciated you. Thank you very much for the most.
Sangamesh.
One more announcement.
Sir.
Please join for the afternoon session by 2:15 because we are very short of time and have to finish it by 5:30. So please, thank you.
एक फोल्डर बनवतो.
Thank you, sir. Everyone, please enjoy the lunch and please be here at sharp 2:15 p.m. Thank you. Also, visit the various stalls present in the dining food area.